Today we have gathered here to enlighten ourselves on the various topics of diabetes. Amongst us are various dignitaries who are present here to throw light on the various topics and just to let us grow our knowledge among the different fields, different topics by their experience, by their knowledge which they have gained over the period of time. So without further ado, I would like to call upon Dr. Manish sir to come on the stage and call upon the various chairpersons and the speaker.
Thank you and very good afternoon. So let's begin the session. It's called B. I would like to invite as a chairperson Dr. Naveen Kumar sir from Darbhanga. Please have a round of applause. Second, we would like to invite Dr. Ubaid Ali sir if he is in. No, he is not in hall. Dr. Sameem sir from Sitamarhi. Dr. T.A. Raza from Purnia. No. Dr. Sujit Kumar from Bihar Sarai. Dr. Rajesh Kumar sir from Darbhanga. Please take your seat, sir. And finally, Dr. Vivek Kumar sir from Samastipur. Is he in hall? No. So let's begin the session. I would like to compress my regard to Dr. Naveen sir to invite the first speaker. Thank you.
Thank you. Very good morning to all of you. Today, our first speaker, Dr. Sweta Verma. He is a consultant physician and diabetologist. Over to Sweta.
Thank you, sir. Good morning to everyone. First of all, thank you, organizing committee, for giving me this opportunity to stand before you all. Today, I am going to discuss a topic which is very highlighted nowadays, that is diabetic reversal. Is it an achievement, a behavior to maintain, or both? We all know diabetes mellitus has turned into a global pandemic with estimation of approx 783 million patients by 2045 worldwide, according to International Diabetic Federation. So we can rightly term this diabetes mellitus as a lifestyle disorder. I will be mainly focusing on, is it a one-time achievement or a continuous lifestyle behavior, both backed by the scientific evidences. Before moving ahead, we all had heard this: let food be thy medicine and medicine be thy food, by Hippocrates. What we have learned in our classical teaching about diabetes, it is regarded as a chronic, incurable, irreversible illness, progressive and lifelong condition requiring a continuous titration of add-on pharmacotherapy, which progresses in over 50% of patients to insulin dependence in 9 to 10 years. But we all as a physician primarily focuses on the glycemic control and treatment of macrovascular and microvascular complications mainly. Now coming to this graph, we can see the natural direction is from left to right in an ascending pattern. So a patient of diabetes mellitus goes through the different phases like pre-diabetes to clinical diabetes and ultimately to the complications phase. So may I ask the audience a question? What are your views on this question? Is reversal of diabetes possible in every patient?
No.
Yes, obviously not. It is not reversible in every patient. Why? The answer lies in this slide. We can see here the direction is from right to left, denoted by the blue arrow. So the remission is possible only in a patient who are in the phase of clinical diabetes or pre-diabetes. Now here you can see on the screen the two terms, diabetes reversal and diabetes remission. The medical consensus prefers the terms remission as it implies a notable improvement that may not be permanent but must be maintained. Rather, I can say must be maintained, not but. So, what is diabetes remission? It is not a cure. Different organizations vary slightly in their criteria as a result of debate around an interest in the diabetes remission. A joint consensus statement has emerged with the following factors: achieving HbA1c less than 6.5% without use of diabetes lowering medications for at least 3 months and reviewed annually as minimum. The ADA had defined the levels of diabetes remission in 3: partial remission, complete remission, and prolonged remission. Now the question arises, why diabetes reversal matters? A patient is benefited in many ways. This can be in terms of reducing the risk of long-term complications like CVD, neuropathy and nephropathy, enhancing the overall well-being, ultimately cost cutting and less expenditure on the medicines, and at last improving the quality of the life. What mechanism lies behind the reversal? There are basically mainly two mechanisms. The first one is reduction in the liver fat, and the second is the decrease in pancreatic fat. The reduction in the liver fat reverses the hepatic insulin resistance, leading to the prompt normalization of fasting plasma glucose within days to weeks. This is the initial rapid phase of development, while on the other hand, the defatting of the pancreas allows the beta cell, which were previously compromised and dysfunctional, to recover their ability to produce and secrete the insulin actively. The other two mechanisms can also be less calorie restriction, which can improve the glucose metabolism, and the last one, increasing the physical activity in day-to-day life, by which enhances the insulin actions in muscles. Now coming to the, as we have cars with the drivers, so the reversals also have the main 5 drivers: weight loss, dietary change, physical activity, lifestyle factor, and the early action. Among these, the weight loss is of utmost importance. Why? I can explain like that. Imagine the every % of weight loss which you flips benefits a new health. Okay? So if we switch the weight by 5%, then our BP and blood sugar calms down. Hit the body weight or lose the weight by 5 to 10%, your body starts cheering up. And again, hit the weight or lose the weight by 10 to 15%, the fatty liver, insulin resistance, lipid profile, and all the parameters starts to be in good level. The other are the dietary changes, physical activity, early action, and the lifestyle factors. What physiological impact it can have on the patient? It can enhance the self-efficacy, sustain good habits, encourages the healthy routines. It can motivate further changes in the weight. It can also foster the pride, create a deep sense of accomplishment and self-worth. This slide shows the diabetes reversal is achievable through targeted interventions. These are the data. One of the most important trial, the direct trial, the diabetes remission controlled trial, in which it was seen that 46% of the patient achieved remission at 1 year with structured weight loss program. Now the other one, the second one is the bariatric surgery. It is very increasing in trend nowadays in the treatment of diabetes or obesity. Among bariatric surgery, the 60 to 70% of patients shows the remission rates in the first year post-surgery. And the last, by cutting the low carbohydrate diet and intermittent fasting, it can also affect significant number of patients. And there comes the limitations of reversals. Considering diabetes as a reversal solely as an achievement can create a false sense of accomplishment, leading to the potential relapse. Now what? The achievement is reached. Here comes the behavior component. It becomes more critical because, as I earlier said, remission is not a cure. Shifting from a one-time intensive effort to a lifelong sustainable strategy is greatest challenge. So, how to maintain the behavior? We have to follow the daily dietary disciplines, regular exercise, and with holistic habits like good sleep, less stress. What behavioral lifestyle approach we can take? We have to shift the focus from temporary diets to lifelong eating patterns with sustainable habits like long-term exercise, periodic monitoring by having follow-up with proper HbA1c, weight, fasting glucose. While maintaining the behavior is possible because consistent behavioral maintenance is crucial to prevent diabetes and returning and ensure the long-term remission. So it's not about the perfection, it's the momentum and percentage, and every percentage point is a win. We can check the weight so that diabetes cannot be reversed by insulin resistance. Body reverts to an insulin resistant state with lifestyle habits means by metabolic benefits weaken when healthy habits relapse. These are the evidence for the behavioral maintenance. In the direct trial follow-up, the remission rate dropped from 46% to 36% at 2 years because the main reason for the decline was difficulty in weight maintenance, and it was observed in patients returning to the high carb diets. So, coming to the role of the diet in reversal, strategic dietary choices are the fundamental for managing glucose levels and promoting fat loss in diabetes reversals with the help of low carb diet, calorie restriction by encouraging Mediterranean diet. Role of physical activity is also of utmost importance because regular physical activity is vital for glucose uptake, weight management. What are the other additional lifestyle measures we can have in our life? Beyond diet and exercise, other lifestyle factors significantly impact the diabetes management and remission, like good sleep, less stress, quit smoking, and moderate amount of alcohol used. Now the major question is, who benefits from the most from the reversal program? Certain individuals are more likely to achieve the success of diabetes reversal through dedicated programs. Those who are recently diagnosed or newly diagnosed, overweight or the obese patients. The most important factor, the patient must be willing, and another most, the family support for the willing patient. What are the barriers for achieving reversal? Diet adherence, social cultural habits, lack of support, emotional eating, access limitations. These are barriers achieving reversal. And what are the barriers in maintaining the reversal? They are again weight gain, regain, inconsistent activity, stress factors, lack of follow-up, and old food patterns. So, in the balanced perspective, we can say that diabetes remission is both an achievement and behavior. It is the two-stage process. The following practical strategies we can adapt: regular follow-up, track progress, joint support group, sustainable meal plans, daily routine activities. So, the verdict, in my opinion, and what is your opinion? You can say, I think it's both, because achieving reversal shows what is possible and maintaining behavior keeps it sustainable. So, this is, you are what you eat, so fuel yourself wisely, you become what you consume. And the lifestyle is the best medication in diabetes reversal programs. Thank you for the patient hearing with these key takeaways.
whether it's a diabetic reversal or remission. Particularly it is based on the lifestyle modifications, particularly in type 2 diabetes, where the main pathogenesis is the insulin resistance. So decrease insulin resistance, diabetes reversal or remission is possible. Thank you so much. Our next speaker is Dr. A.S. Panache. His topic is biosimilar insulin, promises and pitfalls.
Good afternoon everyone, and I express my gratitude to respected chairperson sir and all the seniors who have joined in this session. And my dear friends, we know that the prevalence of diabetes is increasing, and at the same time the demand of insulin is also increasing. WHO has reported in 2021 at the 100th anniversary of the insulin that 50% of patients do not have regular access of insulin in the world. So it is a very pathetic condition. And here the biosimilar insulin can be a game changer. Although in our society and in our practice the use of biosimilar is suboptimal, and although the price is less, but we do not write the biosimilar insulin. So today I am going to discuss about that what are the promises and pitfalls of biosimilar insulins. So in the initial side we will understand the global crisis of insulin and also discuss about the benefits and pitfalls and challenges of biosimilar insulin, and at the end I will discuss about the future innovation which help to the affordable diabetes care. So more than 500 million people are suffering from diabetes worldwide, and although the insulin was discovered 100 years ago, but still insulin is not accessible to numerous number of patients, especially in the low and middle income countries. And reason is behind that the manufacturing is less, the government does not have a regulatory body to authorize the biosimilar insulin in all these countries, and so many other reasons are there. But the important is the cost. If we look on the biosimilar insulin as compared with the reference insulin, biosimilar insulin per cartridge it is 20 to 40% cheaper as compared to the reference insulin. So if we write a biosimilar insulin to the patient, obviously the total cost per month cost will be reduced, and it helps the patient for a better adherence and long-term insulin therapy. And if patient takes an optimum amount of insulin, obviously their glucose control will be there. But here there are some group of patients in the low and middle income countries where SCPs are prescribing less amount of insulin. The reason behind that insulin is unavailable, and that leads to unnecessary admission of the patient at the regular interval of time, and that will increase the expenditure. So we know that insulin was discovered since by the year 1921, and it was a milestone discovery, and till 1980s we are dependent upon the animal derived insulin. Although it is a life-saving drug, but it is also related to allergies and inconsistency and immunogenicity concerns are there. But in 1980 the recombinant human insulin was there, and which is more advanced insulin and have a reduced immunogenicity. And in 1920s, 1990 and 2000, we have insulin analogs, which shows that it is a rapid acting and enhance the absorption and action of the insulin. In 2014, the first time abacaglar insulin was introduced by Eli Lilly in the Europe, and which shows that that is used widely in the Europe till now, and that shows that it is as safe as the reference insulin, and there is no immunogenicity concern is there. So what is biosimilar insulin? Biosimilar insulin is a product that is highly similar to the reference insulin with no clinically meaningful difference in the safety, purity and potency. And if we compare with the generic drugs are the chemical drugs, small structured drugs and easy to replicate, but biologics or insulins are produced in the living system, and they are highly similar but not identical. Complex protein structures are there. So they need a proper complete evolution before the regulatory authorities confirm their use in the public, because they may lead to immunogenicity and allergic reactions also. So regulatory pathways needs totality of evidence, and which needs comprehensive evolution of the insulin. And there are a number of steps are there, like an analytical characterization is there, the detailed structure and function analysis of the insulin were done, in vitro bioassays where cell-based comparing biological activities were done, and clinical trials were done in phase 2 and phase 3 trials, where we know about the drug absorption and distribution of the drug and drug effects on the body, the efficacy of the drug in terms of reduction of HbA1c and glucose control as comparing with the reference insulin, and also know about the safety profile and adverse events and immunogenicity assessment. So if we look on the regulatory milestone, in 2014, Abesaglar was introduced in the Europe and it is widely used, and after 6 years in 2022, Biocon, the Indian pharma company, has launched the Basalog and the semaglutide insulin, and which is used in the US widely, extensively in the US population, and in India also. In 2004, Biocon has introduced the human recombinant insulin Insugen, and later in 2019 they have introduced the Basalog insulin, which is similar to glargine and which is widely used till now. So what are the promises of benefit, whatever term you tell, to use of biosimilar insulin? And the first and important is that biosimilar insulin gives us affordability. It is 20 to 40% cheap as compared with the reference standard insulin, and it helps the patient for the better adherence. It lowers down the cost, and if patient is having an insurance, the reimbursement will be lower. And it also improves the market competition in the healthy way, because many manufacturers were there, so the price is a concern. The originator brand also reduces their price in some extent and increase the patient choice and physician choice also, and there is a market transparency also. The delivery device of the insulin, we know that we are giving the insulin, but dispense is also a problem. So delivery device is also improved by time by the various manufacturing companies. So not only the affordability, but the efficacy of the drug and global equity is also important, and biosimilar insulin has demonstrated various clinical trials in the real world scenario, Swiss trials where the reference insulin is switched to the biosimilar insulin, and biosimilar insulin is switched to the reference insulin, and to know about the efficacy, A1C reduction, fasting plasma glucose reduction, PPBS, glycemic variability, as well as hypoglycemia, weight gain and other parameters also in primary and secondary outcomes. Element trials are there where type 1, type 2 diabetic patients have been used with the biosimilar insulin. Multiple studies, efficacious studies were done to know about the A1C reduction, fasting and PPG reduction is there. WHO also support and advocate to use the biosimilar insulin, especially in the low and middle income countries, and healthcare disparities are there, and universal health coverage is needed for achieving the development goals. And there are some pitfalls also of the biosimilar insulin, and first is the regulatory complexities. We know that in US and Europe there are regulatory bodies which can approve the biosimilar insulin by a way. But in most of the countries in the world, they do not have a regulatory body, so their approval delay is there. So biosimilar insulin is not available. And second dilemma is the interchangeability dilemma. Although we have the results of the biosimilar insulin with the reference insulin, in some countries like Europe and US, the pharmacist can substitute the reference insulin with the biosimilar insulin, or biosimilar insulin with the reference insulin. But in most of the countries like India itself, we are not able to substitute the biosimilar insulin with the reference insulin. So there is lack of consensus of the interchangeability, and that put pressure on the physician as well as the patients also to adopt this biosimilar insulin. So they need a developing framework as early as possible. Another concern from the physician is that manufacturing and the quality control. We know that the biologic drugs are sensitive to the production conditions. Production sensitivities are there, like cell line variation is there. Even a different cell culture produces slightly different proteins. So they will not give a proper result. Temperature control. Minor temperature variation in the manufacturing unit may lead to affect the protein structure. Purification steps, if we alter the purification steps or skip, the product will be different. And storage and stability, cold chain maintenance from the manufacturing unit to the stockist to the retail counter is another challenge. And batch-to-batch variability, cost complication, infrastructure requirements, and risk of product recall, all other consistency challenges are there. So, apart from all these there are immunogenicity concern also. Although also the clinical data says that immunogenicity concerns are very less, but in the real world we feel that immunogenicity concern is there, because if the patient develops anti-insulin antibodies, they require more amount of insulin. 20 to 30% of insulin is required more to achieve the optimum goal, as well as the increased insulin resistance will be there with the biosimilar insulin. So unpredictable glycemic control is there. Allergic reactions are rare, but in some patients the local reactions are there. I have seen one patient in my practice, they develop insulin allergy with a reference insulin, not the biosimilar insulin, but they develop a insulin allergy with a reference insulin. So ongoing vigilance is very much essential to reduce all these immunogenicity and adverse side effects. So acceptance barriers are there, not only by the HCPs, by the patients also. HCPs do not know about the names of the biosimilar insulin. They are not interested to write biosimilar insulin due to the efficacy concern, medical legal consideration. On the other hand, patient is also not so much excited to have a biosimilar insulin and reduce their cost to this system or cheaper alternatives, assistance to the changing therapy and lack of information. So there is a need of our for building trust between the patient as well as HCP to know about the biosimilar insulin and how can we give an affordable diabetes care. If we cut down the price of a drug, to some extent the affordability will be more and patient will more adhere to the therapy, and that need a shared decision making and also need a post-switch monitoring also. So real world evidence, if we look, biosimilar insulin have been introduced in the Europe in 2015 and it is widely used till now, and we have learned that biosimilar insulin produces same effect and same efficacy with the reference insulin largely, and there is a high patient satisfaction also. There are a number of studies have been done in the real world scenario which shows that despite of the as compared to the reference insulin, the satisfaction level is same. And Indian pharmaceutical companies have developed number of biosimilar insulin, and physicians are writing here, and early adoption and better compliance have been noted with the biosimilar insulin. So we need some future landscape and ethical imperatives are there, which need some analytical tools which are developed to reduce the manufacturing defect, that is high resolution mass spectrometry enabling the superior biosimilar characterization, manufacturing the innovation by continuous bioprocessing reducing the cost and enhancing the consistency, digital integration and AI intelligence is there which helps for the patient adherence with the insulin, and also need of ethical framework from the government as well as the authorized body for the informed consent for switching the insulin, transparent communication between the HCP and the patient for the use of biosimilar insulin, and also respect for the HCP choice as well as the patient choice, and equitable access is also important. As well as system level responsibilities are there where fair distribution should be there of the biosimilar insulin and with the quality assurance and standard. So at the end I will summarize the talk with saying that biosimilar insulin are good, they are same efficacy and same safety is there, but it is not used properly, suboptimally utilized in our clinical practice. So with this, I will end my talk. Thank you.
Thank you, Dr. Prakash, for explaining the biosimilar insulin, the promises and the pitfalls in the biosimilar insulin. Our next speaker is Dr. Panache. I would like to invite him. His topic is basal bolus regime versus premixes. What are the selecting the right fit for the patient? So over to Dr. Panache. Is there any series slide?
What we can see is that urban and rural population both have almost similar diabetic profile nowadays. क्योंकि sedentary lifestyle अब गांव में भी हो गया, they are more affluent now. Nobody is riding bicycle or something, they are all having bikes. And urban population वैसे ही है. So dietary pattern और lifestyle, most of the rural population is almost similar और हमारा population भी वैसे ही हो रहा है. सबसे खराब बात यह है कि by 2045 जो prediction है diabetes growth का, it is 134 million, so that is a big growth. And उस हिसाब से देखें कि a lot of people who are diabetic and not under control of OHA, only few of them, almost like 11% of them are on insulin. So the need of insulin is quite more for our patient, लेकिन उनका insulin initiation नहीं होता है. अब देखते हैं what are the ethnic differences जो कि इंसुलिन के एक्शन को डिफर करता है. So Asian Indian population हम लोग सब जानते हैं कि it's a thin fat Indian और इंसुलिन रेजिस्टेंस ज़्यादा होता है because of the abdominal obesity. तो उसमें क्या है कि we have to give more insulin और एक्शन ऑफ इंसुलिन उतना अप्रोप्रिएट नहीं होता है जितना कि हम लोग कैलकुलेट करके डालते हैं. So that is a difficult scenario in our part of population. अब जब ऐसा काम नहीं हो रहा होता है कि even with the doses of the correct doses of insulin, we are not getting proper action of the insulin, and because of that there are higher micro and macrovascular complication in those patients. Mostly हम देखते हैं कि अगर ये 75 ग्राम ग्लूकोज मील टेस्ट कर रहे हैं तो we can see that the postprandial glucose का चैलेंज बहुत है, and that is because the insulin resistance is very high. And हम लोग अभी जैसे डिस्कस किए कि abdominal obesity है. ये दो ग्राफ बता रहे हैं कि when you compare the Caucasian population with the Asian Indian population, तो Asian Indian में postprandial surge बहुत ज़बरदस्त हो रहा है. So that is the one of the main factor that diabetes is driven in India or in this subcontinent is mostly due to a fed state condition, not in a fasting condition. अब need of Indian patient आप देखें कि what are the need of Indian patients. यहाँ पे हम देखते हैं कि carbohydrate is definitely there in all of the India, है ना. various form of carbohydrate है, कोई डोसा खा रहा है, कोई चपाती खा रहा है, कोई राइस खा रहा है, कार्बोहाइड्रेट का फॉर्म्स है. बट इसमें हमारा अगर हम देखें कि इस ग्राफ में 35% ऑफ द इंडियन पॉपुलेशन वो है जिनका मील 70 to 80% ओनली कार्बोहाइड्रेट है. एंड दिस इज व्हाट वी गेट इन आवर क्लिनिक एज वेल. हम लोग का जो सब लोग बिहार से हैं और अगल बगल की जगह से हैं, हमारा ऑल द पेशेंट्स दे आर ईटिंग राइस वंस अ डे एटलीस्ट. तो ये एक चीज़ तो है ही फैक्टर जो कि हमारे ग्लाइसेमिक कंट्रोल को अफेक्ट करता है. तो हेल्थ केयर प्रोफेशनल व्हाट दे नीड टू फोकस इज टू इनिशिएट इंसुलिन on targeting both fasting and postprandial blood sugar levels, not just by focusing on the fasting blood sugar levels, जो कि वेस्टर्न वर्ल्ड में जनरली दे स्टार्ट विद द बेसल थेरेपी और फोकस करते हैं फास्टिंग को और उसके बाद ऑटोमेटिकली पोस्टप्रांडियल घट जाता है. वैसा नहीं है. ADA स्टैंडर्ड्स ऑफ केयर में अगर देखें कि व्हाट आर द एल्गोरिथम फॉर स्टार्टिंग मेडिसिन, तो वी ऑल नो कि हम लोग आजकल के लिए कैसे करते हैं. ASCVD है तो GLP जाना है, हार्ट फेलियर है तो SGLT2 जाना है, मेटफॉर्मिन का रोल थोड़ा सा लिमिटेड हो गया है. एंड देन अगर उससे शुगर कंट्रोल नहीं होता है तो देयर आर वेरियस OHAs like sulfonyl, urea, thiazolidinediones and so on. And then the role of insulin is there. Starting of insulin should be done with the basal और 0.2, 0.3 से करना है, फिर 0.5 तक ले जाना है और उसके बाद उसमें मोलसेस ऐड करने हैं. बट देयर इज अनदर टेक्निक कि आप प्रीमिक्स डालिए, बिकॉज हमारा मील पैटर्न वैसा है कि दो एंड पर हमारा पॉपुलेशन ज़्यादा खाना खा रहा है, मॉर्निंग एंड नाइट, बिकॉज यहाँ पे आफ्टरनून मील इज अ हेडेक फॉर आवर पेशेंट. वो काम करने जाता है एंड डू नॉट वांट टू कैरी मील अलोंग, तो वो चाह रहा है कि हम फुल होके निकले सुबह में और वापस आके हम फुल हो. सो दैट मील इज एक्चुअली वर्क फॉर द पेशेंट, जो कि वो काम नहीं करना चाहता प्रॉपर्ली. तो हम उसको प्रीमिक्स डालते हैं तो हमारा बेटर रिजल्ट आता है यहाँ पे. सो दिस इज व्हाट इट्स सेइंग. अब न्यूली डायग्नोज्ड है तो मोस्टली इफ यू स्टार्ट अ न्यूली डायग्नोज्ड विद द इंसुलिन, वो आपको छोड़ के दूसरे डॉक्टर के पास जाएगा, ये फैक्ट है, और दूसरा डॉक्टर उसको OHA लिखेंगे. दिस इज अ फैक्ट. बट देन इफ यू स्टार्ट अ न्यूली डायग्नोज्ड, सपोज द पेशेंट टेक्स द इंसुलिन, तो हम लोग को स्टार्ट करना है बेसल इंसुलिन से, उसको इंटेंसिफाई करना है. बट देन अगर हमारा उससे कंट्रोल नहीं होता है तो मॉर्निंग टाइम हमको OHA देना है टू कवर द पोस्टप्रांडियल ब्लड शुगर लेवल्स. एंड देन मॉर्निंग टाइम OHA हम दे सकते हैं पेशेंट के कंडीशन को देखते हुए. इफ द पेशेंट हैज गॉट कॉम्प्लिकेशन, कार्डियक कॉम्प्लिकेशन, तो SCVT के लिए हम GLP डालेंगे, ओबीस है तो उसके लिए भी डालेंगे, हार्ट फेलियर है तो SGLT2 डालेंगे, एंड सो ऑन. बट देन अगर हमारा फास्टिंग एंड पोस्टप्रांडियल बोथ आर हाई इन अ पेशेंट कैटेगरी, देन वी शुड स्टार्ट विद द प्रीमिक्स इंसुलिन रादर देन up titrating. So we as a diabetologist, what we are focusing is not just step by step intensification of the therapy, rather than just hitting the target at once. तो पहले से ही प्रीमिक्स डालें जो हमारे पॉपुलेशन को ज़्यादा अच्छा कंट्रोल करेगा. इंसुलिन रेजिमेन यहाँ वही सारे बातें लिखे हुए कि व्हाट आर द थिंग्स दैट वी हैव टू गिव, बेसल प्लस, बेसल बोलस, प्रीमिक्स एंड सो ऑन. तो ये सब डिफरेंट कैटेगरी ऑफ पेशेंट्स है जो हम जानते हैं कि कब कहाँ देना है. ओके, ये प्रैक्टिकल गाइडलाइन है जो कि हमको एक थोड़ा सा सोचने के लिए बताता है कि हमको कैसे जाना है. अगर हमारा सिर्फ फास्टिंग ब्लड शुगर को कंट्रोल करना है तो बेसल इंसुलिन इज गुड एनफ. इफ फास्टिंग एंड पोस्टप्रांडियल बोथ इज द टारगेट, देन प्रीमिक्स इज गुड एनफ. ऑल्सो एक चीज ज़्यादा देखें कि इफ अ पेशेंट वांट्स अ फ्लेक्सिबल लाइफस्टाइल, देन बेसल बोलस इज गुड फॉर दैट पेशेंट. But if a patient has got a fixed lifestyle and is not very active और एक ही टाइप से वो जिंदगी जी रहा है, एक ही टाइप का खाना खा रहा है, then premix insulin is rather better than those basal bolus type. So these are the things. Then number of injections भी अगर देखें तो if we take a full basal bolus, there are 4 shot of injection which is rather only 2 shots in the premix. और प्रीमिक्स में बहुत सारे वैरायटी आ गए जो कि बहुत अच्छे काम करते हैं आजकल. ऑल्सो अगर ये कंपैरिजन देखें तो पेशेंट प्रेफरेंसेस क्या हो सकता है. पेशेंट प्रेफरेंसेस मोस्टली प्रीमिक्स की तरफ होता है बिकॉज द लेसर शॉट ऑफ द इंजेक्शन. ओल्ड एज ग्रुप के लिए ज़्यादा बेहतर है बिकॉज दे एवरी मील के पहले दे डू नॉट हैव टू प्रिक, सो दैट इज गुड. lesser need of the injections होता है, they are more organized with the lifestyle, that means the fixed pattern of the lifestyle, and 2 meals of the day ये रहता है. basal bolus में rather active, highly motivated, उनको हम बता सकते हैं कि every meal के बाद इंजेक्शन, मील से पहले आपको इंजेक्शन लेना है, so that you can cover up every meal और time in range रहना है. तो जो लोग इतना सुनने को तैयार हैं, those who are motivated, they can go for that one. Otherwise हमारा देसी population प्रीमिक्स इंसुलिन से ही है. Why choose premix? Fewer shots, better control, less dosing errors, and convenient. So these are the things that we have already discussed. Types of premix. Now we are seeing there are so many types of premix. Human insulin है, analog है, and there are co-formulation also. So depending on the type of the patient which you are prescribing, the purchase capacity of the patient, the need of the patient, you can give any of the injections. Different guidelines. Sorry. Different guidelines all have suggested the same thing, that you start with the basal, then go with the basal bolus, or then premix as needed to intensify the therapy, or if the patient lifestyle is such that premix is more convenient, or the dietary factor is such, if the premix is more convenient, you go with that one. Now positioning premix insulin according to the RSSDI guidelines. So this is what we are all practicing, that you start with the basal bolus, or if the patient needs a premix insulin depending on the lifestyle, then you start off with the dosing of the premix. Start करें 10 units से and then up titrate करें. बेजल का हम लोग को पता है 0.2 से शुरू करना है या 0.5 तक लेके जाना और उसके बाद बोलसेस ऐड करना है। Which premix insulin? So अगर डाइट बहुत ज़्यादा है, if the patient takes heavy meal तो you can give 50-50, रात में कम ले रहा है तो you can give 30-70. For a basal acting, more part of the basal acting, less chances of hypoglycemia. You can mix and match 50-50 morning, 30-70 night, or both the time 50-50 or both the time 30-70. So this is on your preference. Individualize कीजिए patient को और उस हिसाब से patient को insulin दीजिए। Expert opinion ये सारे उसी के बारे में बातें हैं। ये है इनिशिएशन के लिए कि राइट मिक्स किसके लिए। अगर हाई पोस्टप्रांडियल ग्लूकोज लेवल है तो 50-50 हम देंगे, हाई कार्बोहाइड्रेट मील से तब भी 50-50 देंगे। इनकंसिस्टेंट टाइमिंग एंड कंटेंट ऑफ मील्स है तो हम लोग बेसल पे जाएंगे। नॉक्टर्नल हाइपोग्लाइसीमिया का ज़्यादा डर है तो विल गो विद 50-50 इन मॉर्निंग एंड 30-70 इन द नाइट। इन आफ्टरनून में हाइपोग्लाइसीमिया हो रहा है तो लो मिक्स दैट इज 30-70 पे जाएंगे। टेकिंग सल्फेनाइलूरिया, सो बेसल, सो पुराना तरीका था बेड टाइम इंसुलिन एंड मॉर्निंग टाइम सल्फेनाइलूरिया, सो इसमें वो है। इंटेंसिफिकेशन में पेशेंट प्रेफर्स फ्यूअर इंजेक्शन, वी कैन गो विद द प्रीमिक्स। Able to conduct frequent glucose monitoring, then we can give the basal bolus or basal only, or inconsistent timing and the content of meal basal of course उस हिसाब से देंगे जैसे जैसे वो खाना खाएगा, ज़्यादा flexible रहेगा। So these are the same thing titration करने का तरीका that we have discussed. All these graphs are showing the same thing कि how we are going to titrate according to A1C and the blood sugar levels. Same thing. Now switching strategy, we just discussed that how we switch. ओरल है वहाँ से इंसुलिन पे गए एंड देन कैसे उसको स्विच करेंगे फ्रॉम बेसल बोलस और प्रीमिक्स, क्या क्या चीज़ें करेंगे। सो दीज आर द डिस्कशंस। द यूज इन एल्डरली, व्हाट द गाइडलाइंस सजेस्ट, यूज ऑफ प्रीमिक्स इंसुलिन pen should be encouraged in geriatric population to minimize the dosing errors and to potentially improve the glycemic control. Frequency of hypoglycemia event can be lowered in older patients by using NPH then or human premix analog instead of NPH or 30 or human 30-70. दो केसेस है जो कि देख लें जस्ट फॉर द रेफरेंस कि अगर ओल्ड पर्सन है मिडिल एज and the patient is having high A1C, fasting and postprandial blood sugars are also high, and then problem of OAD failure is there and high spikes of the sugars after meal, then what we give 30-70 twice daily, and outcome is better A1C and better A1C and better postprandial sugar also. In this, what the learning is there, that effective control is there, less pricks are there, and well suited for Indian population who are taking high carbohydrate. Then second case is there where nocturnal hypoglycemia is there. Here we can give a mix of 30-70 and 50-50 so that the nocturnal hypoglycemia is corrected and the patient can also achieve a better A1C. So these two cases summarizes what I just wanted to tell, that in our part of the world where the carbohydrate content of the food is very high and people are generally not taking 5 meals as we suggest to the patient, rather than they are just taking 2 very high carbohydrate food, and in spite of OAD, if the blood sugar is not under control, it is advisable to give a premix insulin twice daily, or the choice of premix could be individualized, and it will definitely have a better sugar control than a basal bolus regimen in our part of the world. So with this note, thank you very much for patient listening.
Thank you, Dr. Kumar. Your talk was very clinical oriented, and we have learned how to switch to insulin and everything. It was very nice presentation. Thank you.
Thank you, sir.
We'll be talking on diabetes in critical care, insulin infusion protocols. Over to you, Dr. Abhishek Chowdhury.
Everyone, sorry for the little technical delay. So we will start off with the topic. My topic is very clinically oriented and a topic which we have been dealing every day in our critical care settings and also in the hospitals. All of you have been dealing. So it is management of in-hospital hyperglycemia and critical care setting. So what is coming with the definitions first? What is actually in-hospital hyperglycemia? So how do we define it? So when a patient comes to the hospital, we do a blood sugar test. Anything in a critical care setting, anything above 180 is considered, we have to check HbA1c levels. So a fasting blood plasma glucose greater than 126 according to the guideline, postprandial of greater than 200 and HbA1c of greater than 6.5. Or somebody who has a classical symptoms of hyperglycemia with a random glucose of greater than 200. This can help in diagnose diabetes and differentiate it from stress hyperglycemia. Of course, critically ill patients will be having a lot of conditions, will be in a lot of medications, so we have to differentiate. So what are the barriers which we face normally in the hospital when the patient comes? Diet, of course, critically ill patients in their diet, variable meal time, patients may be NPO, somebody might be posted for a surgery, some persons may have an acute illness or a psychological illness, impaired renal function, liver function, they may be on medications which might elevate, like steroids, it might elevate the sugar, drug-to-drug interactions, of course, patients are on multiple drugs, and of course, timings, we write the drug timings, like we advise a timing in the drug chart, but when it actually comes to the patient, what time the nurse is actually giving to the patient actually varies. So, in all patients, in all in-hospital patients, it has been shown that hypoglycemia as well as hyperglycemia both play a very important role. Both have to be managed, and hyperglycemia is also not only hypo, but hyperglycemia is also associated with the increased complications, increased length of stay, and mortality. And whenever patients come to us with diabetes or elevated sugars, the intricate balance has to be managed between hypoglycemia, hyperglycemia, and glycemic variability, which can lead to adverse outcomes and mortality. Sure. So, careful equilibrium between hypoglycemia and hyperglycemia has to be maintained. So, according to the latest ADA guidelines, hyperglycemia in hospital individuals defined as sugar levels of greater than 140 and admission HbA1c of greater than 6.5%. So, if somebody has HbA1c elevated 6.5%, we have to evaluate. And not only the sugar, but the levels, but also the glycemic gap and the glycemic variability. The fluctuations in blood sugar. Somebody who has a normal fasting glucose, but his sugars are fluctuating during the stay in the ICU, it increases the mortality, morbidity, and also the length of stay. So, in non-ICU setting, we take the goals are between 100 to 180, and in, of course, critically ill patients, somebody with a heart failure or a kidney failure or a CKD patients, we increase the upper limit to up to 250. So glycemic goals, again, this is showing the same, mostly critically and non-critically 140 to 180, and in selected patients, the therapy has to be individualized. No guideline says like it has to be followed like a Bible for every patient, it has to be individualized. So now coming to the evidence, what does the evidence say? So this is a study, Vandenberg et al. Study which was done, and as you see from the Kaplan-Meier graphs, it shows that the survival in ICU and in-hospital survival both was shown to be better with the intensive glucose control. Okay, so this is what it showed. And then, but the nice sugar trial which was done, normoglycemia intensive care evaluation and survival using glucose algorithm, it showed a better outcome with the conventional glucose control method rather than intensive glucose control method. So at the end of it, two trials are showing different things. Now what should we do? All of you remember this scene? Can you remember this scene, movie scene? This from 3 Idiots, when Amir Khan gives the bookish definition of book definition according to the dictionary. So वो कहना क्या चाहते हो, आप बोलना क्या चाहते हो, फॉलो क्या करना है, मतलब टाइट कंट्रोल करना है या कन्वेंशनल मेथड यूज करना क्या है? So this was the Leuven. This shows a summary of the Leuven randomized control trials which were done. It shows that every patient has to be individualized, and for monitoring blood glucose levels, we have to be very careful. We have to use trained personnel. We have to measure the blood sugar levels carefully. So this trial which was done, not in India but outside, it showed that the measurement site was predominantly arterial glucose measurement. It was done using an arterial blood gas analyzer, and they used only insulin infusion methods. no bolus methods, and also, in the last one, very important, well-trained nurses were taken care of who knew how to do what they were doing. Only then it showed a better outcome with tight glucose control in critically ill patients. But then again, the summary of the clinical trials showed, all the clinical trials summary showed that intensive glucose control has to be done, but with a pinch of salt. For every patient in the ICU is different. Whether it's a trauma patient, it's a heart failure patient, it's a CKD patient, it's a sepsis with septic shock patient, it has to be individualized. We cannot do it all, put everybody in the same boat. So coming to the management in critically ill patients. So this algorithm is very common, everybody, all of us are following this. Somebody comes, we find elevated blood sugar levels. Of course, if they are in the ICU, they're critically ill, we stop all oral hypoglycemic drugs and we monitor the sugar. Then we start them on bolus doses, and then if needed, we when the patient condition improves, we switch to basal plus bolus. Coming to the infusion protocols in critically ill. So the insulin infusion protocol is much more targeted to the rate of blood glucose correction than directly to blood glucose normalization. Of course, the fluctuations of blood glucose, the variability has to be managed. And of course, when this patient's sugar is going below 150, we have to take care of, we have to prevent rebound hypoglycemia. So this table just shows a summary of the various protocols. We can use an insulin infusion method, or a sliding scale, or a complete basal plus bolus. Basal plus bolus, Dr. Kunal Kunda has explained very well. So just coming to the disadvantage, every strategy has a disadvantage. Insulin infusion, we have to have trained nurses, we have to be somebody who is monitoring the patient regularly, the sugar levels, watch for hypoglycemia. Even the sliding scale, it has ineffective, severe hypoglycemia have been seen, increased glycemic variability, and this basal plus bolus requires daily assessment and titration. And of course, the nutritional needs of the patient have to be seen, the sugars fluctuate according to that. So this is again roughly what all of us know. When a patient comes to our ICU or hospital and the glucometer shows a high level, it does not show, or it shows a 500 or 600, the blood glucose level, what do? We divide it by 100 and we start like 600, we start with 6 units per hour insulin infusion, and then we titrate it according to half hourly or hourly. So, but the main motto is do not increase insulin rate more than 10 units per hour at a time, and keep watching. So this is again, it compares the sliding scale insulin regimen with the basal plus bolus regimen. So the main, our purpose is to, the sliding scale insulin, the main thing is that it gave a roller coaster thing. The glycemic variability was too much. It was non-physiological, poorer glycemic control, and also it was not individualized. And it is more of a reactive approach than a treatment approach. We see a sugar level, we give insulin. Again, we see a sugar level, we give insulin. So the basal plus bolus regimen was more physiological. ADA recommended improved glycemic control, fewer hyperglycemic and hypoglycemic episodes. So this graph shows a better management with basal plus bolus regimen, significant improvement in basal plus bolus regimen. Managing in-hospital glycemia. So the table shows when the patient comes in the hospital or the ICU, what do? We stop all oral hypoglycemic drugs, we start them on insulin, IV insulin in critically ill patients, and if non-critically ill, we can give a trial of subcutaneous. But then insulin infusion, when do we give insulin infusion? Uncontrolled diabetes, stress, infection, pressure, severe pain, cardiac surgeries, transplant surgery, somebody who is going to go cesarean section or labor, high dose, somebody is on high dose steroids, or requiring dextrose containing infusions. So these are some of the names of the protocols again, because my topic was insulin infusion protocol. So the Portland protocol, Leuven protocol, Yale, Gans, Cup, there are many protocols, but no protocol is made for all patients. It has to be individualized. We can use it as a guide, but we have to individualize. This is what I want to say. So this shows how the dilution is done, but how many of us actually do it? We ask the nurses to do it, but how is it actually done? We have two kinds of insulin syringes. For 100 unit per ml insulin, we prepare it by adding 0.5 ml of sodium NS with 49.5 ml, and for 40 units, we prepare 1 ml of insulin with 39 ml, and then we started the IV and we monitor. So roughly it is started initiated at 0.1 unit per kg per body weight. The starting dose can be according to the current blood glucose level, and later we keep on increasing or we decrease. So this roughly, I have shown this one protocol, which is the Yale protocol, same which we have been following, but of course we have to modify it. So check blood glucose until stable, 3 consecutive values within target range. Glucose level of less than 140 or greater than 140 is not recommended. Changing the insulin infusion rate, of course, all of us are aware of that. Coming to the next half. So this also shows the same. The changes in infusion rate determined by the current rate. So coming to the diabetic emergencies, the most common diabetic ketoacidosis and hyperglycemic state, hyperoxemia, hyperglycemic state. So uncontrolled hyperglycemia, uncontrolled metabolic acidosis. Of course, the patient is they will need IV insulin therapy and titration. Showing the diagnostic criteria. All of us are aware of this. Okay, so how do we do it? When the patient comes in with these two states, what do? We first have to hydrate the patient and check the blood glucose levels, check the ketone levels. We give them bolus of fluids and then we start insulin. Before starting insulin, we have to be aware of the electrolyte levels, the potassium levels. Accordingly, treatment with IV fluids. Of course, if the patient's glucose goes down after treatment, we have to take care of the rebound hypoglycemia. Potassium levels, we have to be very careful whether there is hypokalemia or hyperkalemia. Coming to bicarbonate. Bicarbonate is a very important part of management of diabetic ketoacidosis and HHS, and it is a part. How many of you are actually using bicarbonate in your therapy of DKA and HHS? How many of you have actually used it? So let me come to this. This is a very important part of the topic, and it is that it is still a topic of debate. The only trials which have been done are for those. Only one trial has been done till now, randomized control trial, which consists of the pH was 6.9 to 7. So those whose pH was less than 6.7 but above 6.9, and it contained only 21 patients. And in those, when they gave bicarbonate, it was found that it was not found to be, it did not change mortality or morbidity in patients who did not receive it. Normally, volume expansion and insulin improves it.
And we are running like
So, this is the treatment of diabetic ketoacidosis and HHS. All of us are aware of this. Treatment, we check the this one electrolytes and we keep a track. Transition to subcutaneous insulin. Once the patient becomes stable, you can change to subcutaneous insulin. Treatment, of course, again the same slide has been shown in a more detailed way. Transition from IV to subcutaneous, we have to remember so that we give a subcutaneous dose before stopping the IV insulin. So again coming to the same, that glucose lowering, basal plus bolus correction was found to be better, and stable blood glucose levels, stable nutrition plan, hemodynamic stable, patient's hemodynamic stability also plays a vital role. Unsafe indicators for transition from IV to subcutaneous. Other factors of poor transition: if the patient is at advanced age, poor HbA1c, ICU status, receiving steroids. Transition from IV to subcutaneous, again, which I said just now. So the dosing, the basal plus bolus regimen was found to be better, but this is how the calculation, all of us knows, I can't go into detail, we are running short of time. So again same, not much in this. This shows the outcome, which shows a better basal plus bolus with basal plus bolus outcome and the regular monitoring. What are the challenges we face? Complexity of insulin regimen, self-administration challenges, lack of medication, and fear of hypoglycemia. Planning for discharge, discharge planning has to be done properly so that the length, again readmission rates are less. So these are again different factors to take care in the discharge plan. Planning discharge from hospital is very important. So this is again a recommendation by RSSDI, those HbA1c less than 8, those with 8, those with less than 5.7, how to differentiate between stress hyperglycemia. Same again, this thing. So coming to summarizing the talk, summary of the recommendation. all patients admitted to critical care with a blood glucose of 126, we have to do a HbA1c, we have to monitor the glucose levels. It is important to categorize hyperglycemia and hypoglycemia and monitor them. And those with new onset hyperglycemia, we have to see differentiate. And stress hyperglycemia, of course. This is the secure model which was done. It stands for severity, hyperglycemia, expected prognosis, concomitant death current urgency, and risk of hypoglycemia. This shows, if you see, look into it, that the slow low therapy or the fast high therapy has been differentiated according to the drugs which patients are getting and their diagnosis. It has to be individualized. So, coming to the last slide. Hyperglycemia in hospital setting can reflect. We have to be very careful, we have to take care of it. Considering the right dose and the right insulin and the right mode of administration is very important. Continuous blood glucose monitoring is very important. Thank you.
Thank you, Dr. Abhishek. Your talk has really enlightened us, especially for those who are working in busy ICUs. Thank you.
Thank you to all the speakers for such an enlightening talk. I would like to call upon the moderator and the chairpersons to felicitate our speakers.
Now the house is open for the question and answer. If you have any question, you can ask. Dr. Abhishek, I have a question. When we start IV insulin to any critical patient in ICU setting, whether it's a patient of DK or hyperosmolar coma, when the patient is settled, we switch over to the subcutaneous insulin. So if we are giving total 75 units of insulin per day IV, how can switch over to the subcutaneous insulin, and which type of insulin is better, and what is the time, what is the window period from switching IV to subcutaneous insulin?
So actually, I had to run through the slides, and it was there the total daily dose calculation. So the total daily dose 24 hours what we used, and in 24 hours how much insulin the patient had got, and we take that dose and we divide it according to what we do with basal plus bolus. We divided 80 and 20. So but of course we have to monitor the patient. What I do in my clinical practice is that when the patient is recovering, I start them on a long-acting insulin and watch the insulin, the sugar levels properly, and then start a short-acting insulin together. And then on discharge, according to the HbA1c levels of the patient conditions or whatever was his first on admission his condition, I put them on an oral hypoglycemic drug with a long-acting insulin or a short-acting insulin. But sir, yes, the slide was there, total dose calculation.
But what is the window period? If the patient is on IV insulin, with just start the subcutaneous insulin, there is a window period.
Yes, sir. We have to overlap.
The subcutaneous insulin reaches to the blood after some time.
Yes, sir.
So I think it's a two hour before we have to start the subcutaneous
most
insulin.
commonly, so the nurses forget. Even though we mentioned it in the file, they forget to give it, and then the next sugar level is very high.
But it depends on the plasma half-life itself, because the IV insulin has got only 2 or 3 minutes of plasma half-life, whereas intramuscular is 2 to 3 hours rather, and I think for a subcutaneous 4 to 6 hours. If you will rearrange or arrange all the suboptimal dose what you are given in 24 hours, it is divided up to the plasma level or up to the calculation what you show in the slides.
So calculation should be done, but mostly we did it when we were in residential.
Actually, it's a complete clinical right, very well said, very well, and wonderful presentation. Thank you all. If any other question, I would like to have only one question I could allow. Over. Thank you. So I would like to conclude the session. Thank you. I'd like to Dr. Gavin sir and Dr. Rajesh, please be on time with all the speakers.
Dr. Shweta Verma sir.
प्रोजेक्टर पे कोई जान दो ना इस प्रोजेक्टर
Dr. Panache.
हो जाना
थोड़ा पीछे
भेजते जाइएगा।
Dr. Abhishek Chaudhary, sir.
Please come, we'll have a group. Come fast.
सर थोड़ा सा पीछे
The moderator.
चश्मा पे ठीक आ रहा है ना फोटो जी?
अब जल्दी खींचो, बहुत हो गया, पेट नहीं खींचे।
चलिए अब आप सेकंड सेशन।
Thank you. This concludes our first session. Now for the second session, I would like to call upon the moderator, Dr. Chaitanya Prakash, sir.
Good afternoon, everyone. I am the moderator here in this session. My name is Dr. Chaitanya Prakash. I am from Patna. And today we will have a discussion on how elderly care is done if the patient is diabetes and also having more comorbidities, and also as the life expectancy is increasing nowadays, there are more elderly patients seen today with diabetes and other comorbidities. So now we will learn today that how we will manage and how properly we will manage to not get them into hypoglycemic state, and also how to provide them with proper nutrition, and also they can live their life with dignity. And that is the whole session today. And now I would like to call our respected chairpersons, Dr. Nikhil Goyal from Patna, Dr. Indu Prashad from Patna, Dr. Abhay Chaudhary from Patna, and also I would like to call our first speaker, Dr. Dharmendra Singh from Bihar to give his lecture on DM in elderly frailty and individualized target. Thank you.
Hello everybody. Now I invite the first speaker, Dharmendra Singh from Bihar Sharif. And the topic is DM in elderly frailty and individualized target.
Thank you, speakers. Thank you, chairpersons, seniors, and my dear colleagues. First of all, I would like to thank the team RSSDI for giving me this opportunity to speak in front of you. The topic for today's discussion is diabetes mellitus in frailty and individualized target. So we all know that with advancing age, the incidence and the prevalence of diabetes increases. So diabetes in elderly, what does it matter? Diabetes in elderly adults is a major clinical and health challenge due to increased life expectancy, high prevalence of metabolic syndrome, sedentary lifestyle and nutritional changes, polypharmacy and multiple comorbidities will be seen in these patients, and high risk of frailty and disability. Unique feature of diabetes in the elderly, these patients often present with atypical symptoms like fatigue, confusion, infection rather than the classical symptom of polyuria, polydipsia, polyphagia. Elderly patients often have impaired counter-regulatory hormone response. They have higher glucose variability, poor appetite, malnutrition, and reduced renal and hepatic reserve, which leads to repeated episodes of hypoglycemia, which is more dangerous in this sex of people due to increased risk of fall, fracture, myocardial infarction, arrhythmias, and cognitive decline, which might ultimately lead to mortality. Importance of individualized target. Chronological age is not equal to the biological age. As we all know that the chronological age depends upon the date of birth, whereas biological age depends upon the physical fitness, robustness of the health, and for each and every person we have to have a personalized glycemic goal. Frail patient often requires relaxed glycemic targets to avoid hypoglycemia, and in treatment plan we must consider the cognitive function, physical fitness, support system of the caregiver, along with the caregiver, life expectancy and comorbidity burden. Elderly diabetes is typically defined as any individual whose age is more than equal to 65 years of age with type 2 diabetes. However, the functional age or the biological age is more important than the chronological age. AD also categorizes these sets of people based on their physical fitness rather than the chronological age. Frailty is basically a biological syndrome of decreased physiological reserve in multiple systems, leading to reduced physical strength, decreased endurance, increased vulnerability to stress. And sarcopenia, it is progressive and generalized loss of skeletal mass and strength, which is accelerated in these sets of people due to chronic inflammation, mitochondrial dysfunction, insulin resistance, which ultimately leads to, and also is a predictor of disability and functional decline. As I have already said that frailty is not a disease but a clinical state characterized by diminished strength, endurance and physical function that increases the individual's vulnerability and dependency on the others. We have two frailty scales. One is frailty phenotype and another is clinical frailty scale. A person is said to be frail according to frailty phenotype if he meets more than equal to 3 criteria of the underlying 5, that is unintentional weight loss of more than 4.5 kg or 5% of body weight in a year, exhaustion, weakness, slowness, and low physical activity. A person is said to be frail if he has 1 to 2 criteria of the above, and the clinical frailty scale, it goes from 1 to 9, where 1 is very fit and 9 is terminally ill, with 5 in between, that is mildly frail. Causes of hypoglycemia and frailty is because of diminished gluconeogenesis, reduced muscle and liver glycogen in these sets of people, impaired autonomic response, behavioral fluid intake, and polypharmacy. Frailty alters drug pharmacokinetics, which leads to reduced renal and hepatic clearance of drugs, which leads to higher plasma concentration and ultimately adverse effects. With the advancing age, we see functional dependence and this cognitive decline. So, tailoring glycemic targets based on frailty. So, goals must shift from tight control to the safe control. Global diabetes burden. Currently, we have some 529 million people suffering from diabetes in the elderly population, which is projected to increase to 1.31 billion by 2050, and the current prevalence is 19.3. In Indian diabetic scenario, we have some 101 million people suffering from diabetes currently, which is projected to increase to 278 million by 2050, and the overall prevalence is 24.3%. Physiological changes in aging that affects glycemic control. As we all know that with aging, the incidence of diabetes increases because of beta cell apoptosis and increased insulin peripheral resistance, which leads to hypoglycemia and type 2 diabetes. Physiological changes with aging that affects glycemic control. As with the advancing age, the renal function declines, and so does the GFR, which leads to decreased drug clearance and increased risk of hyperglycemia because of musculoskeletal. With the advancing age, we have sarcopenia, which alters the insulin sensitivity, which ultimately leads to the overall insulin requirement in this age group. Neurologic and autonomic, we see hypoglycemic unawareness in these patients, and there are also incidences of orthostatic hypotension. And with the hepatic and metabolic, we see altered drug metabolism, which leads to variable postprandial glycemic control. So intensive glycemic control leads to repeated history of hypoglycemia and downstream events, which is detrimental in these patients. It has been substantiated by the two, there's ACCORD and ADVANCE trials, and so we need to have a individualized balance between type control versus patient risk. So we can see that from the ACCORD trial that the number of incidents of hypoglycemia requiring medical assistance is more in intensive arm in comparison to the standard therapy. Same was the case with the ADVANCE trial. So severe hypoglycemia occurred more frequently in the intensive care group rather than the standard control group. So clinical manifestation is atypical in elderly. There is polyuria, polydipsia may be absent. Symptoms may present as fatigue, cognitive decline, recurrent infection, falls, weight loss. There might be blurring, visual blurring, neuropathic symptoms, nocturia, postprandial hypoglycemia, and dehydration. Practical HbA1c targeted by clinical context. Healthy adults need to have HbA1c of in between 7 to 7.5. For mild to moderate, we need to have in between 7.5 to 8. And for severely frail patients, we need to have HbA1c of in between 8 to 9. So, composite risk stratification for individualized goal, we need to evaluate frailty, life expectancy, functionality, and cognition, taking into account of the comorbidities like coronary artery disease, chronic kidney disease, chronic liver disease, and episodes of hypoglycemia. We need to review the medications and set individualized target for each and every person. Diabetes and CKD staging, impact on drug safety and targets. If the eGFR is more than 60, then most of the oral hypoglycemic are usable. We just need to monitor the renal function. In between 30 to 59, SGLT2 inhibitors and DPP4 inhibitors are very good. Metformin dose adjustment is required. And if eGFR is less than 30, then most of the oral hypoglycemic becomes contraindicated. Favor goes for the DPP4 inhibitors in the dose titration according to the CKD staging, and we need to be careful with the insulin use in this sets of population. So drug classes and hypoglycemic risk and suitability. Metformin, they have got a very low hypoglycemic risk, and dose adjustment is required if eGFR is less than 45, and we need to stop if it falls below 30. Sulfonylureas, they have got very high hypoglycemic risk, so we need to avoid glimepiride and gliclazide and use caution in especially in CKD patients. DPP4 inhibitors, they have very good low hypoglycemic risk. Some agents require dose adjustment. SGLT2 inhibitors also have a very good hypoglycemic profile. They have a low hypoglycemic risk, and there is some renal benefit of using SGLT2 inhibitors in CKD patients. GLP-1 inhibitor receptor agonist, they have a low hypoglycemic risk, but in this sets of people, weight loss may be detrimental. Thiazolidinones, we need to avoid in those in patient with CHF, as that leads to fluid retention and repeated episodes of hospitalization for heart failure. Insulin, we have high.
2 more minutes.
Insulin, high hypoglycemic risk, and we need to simplify the insulin dosing. Indication for insulin in this is symptomatic hypoglycemia, inability to take oral agents, uncontrolled despite safe oral therapy. So we need to start with the basal insulin once daily or low dose short-acting insulins, and monitor, self-monitoring is better. So deep prescribing and simplifying regimes, we need to identify high-risk medication like sulfonylureas and glenites, and we need to switch over from the complex insulin regime to the simple one, assess individual targets, taper and discontinue the unsafe drugs, and active monitoring after change. So monitoring plan, we need to monitor HbA1c every 3 to 6 months if we are changing the therapy, and if the patient is stable, then we can do it every 6 to 12 months. Self-monitoring of blood glucose is best for these sets of people. If not, then we can switch over to the lab. And we need to monitor renal function and electrolyte imbalance for every 3 to 6 for changing therapy, and red flags for the escalation, dose escalation, when we see there is recurrent episodes of hyperglycemia or when there is weight loss or fall. So addressing hypoglycemia, recognition, prevention and emergency. Best is to prevent hypoglycemia. Then recognition is by the typical symptoms of hypoglycemia, which is headache, palpitation, sweating, perspiration, confusion, dizziness, and emergency treatment. As soon as we recognize hypoglycemic episode, start with the oral glucose. If not, then IV dextrose can be started in the hospital setting.
Time up.
Nutritional, these patients are very frail, so we have to take into consideration the nutrition. So I would just want to show this slide. Intensive control causing recurrent hypoglycemia. Here we have 72-year-old male, CFS4, who has repeated episodes of nocturnal hypoglycemia and whose HbA1c is 6.5. So we need to change the target from 6.5 to 7.5 to 8 HbA1c, stop glimepiride and long-acting insulin, start basal insulin and monitor. So myth, tight HbA1c is always better. That is not true for these sets of people, which it becomes detrimental. Ignoring renal function is a real problem. The patient might, because of the ignorance of the renal function, this patient can have repeated episodes of hypoglycemia, overlook it, and there's another pitfall, overlooking functionality and cognition. We need to correct and prioritize simplicity over the complexity of the drugs. Take-home message: assess fragility, cognition, functionality, and renal status, set individualized targets, review and deep prescribe high-risk drugs, plan timely home follow-up. Thank you.
Very wonderful presentation by Dr. Dharmender. And now I invite the next speaker, Dr. Angad Kumar, who is going to discuss the futures of diabetes trial and what are the prognostic and adaptive designs of that trials.
Good afternoon, everyone. To all panelists, colleagues, august audience, and office bearers of RSSDI. At the outset, I would like to extend my sincere thanks and regards to office bearers of RSSDI for their generous invitation as a speaker for this session. I'm not taking too much time into context statement. I will just move through them.
topic provided to me, that is future of diabetes trials, pragmatic and adaptive designs. Kind of a catchy and new name for everyone, particularly if you are not into research part. So after the continuous evolving paradigm of diabetic mellitus, we need newer innovations. As at the end of every 1 year, we are facing that some new molecules are in pipeline. We are talking about complete reversal of type 2 diabetes. We are talking about stem cell therapy for type 1 diabetes. With that regard, the traditional gold standard, that was randomized controlled trial, that is not able to keep pace. And it is not truly representative of real world scenario where we talk about people with comorbidity, people with polypharmacy. We have people who have very variable adherence, and there is underrepresentation of many population. So undertake all these issues, we have to design a trial that is more pragmatic and more adaptive for the same. Now coming to the topics, this is the outline along which we will move for the next 10 to 12 minutes. First, why traditional randomized controlled trials are failing modern diabetes research. Adaptive designs, optimizing trials in real time. Pragmatic design, bringing trials to real world practice. Implementing innovation, what is the practical applications, and what are the future direction and key takeaway from this topic. As we all know, the pace of our clinical trial is very tedious, it is cost intensive, and for any trial, from the inception of the trial to the approval of drug, it takes about 8 to 10 years. And as we know, once we have started the trial, when the trial is complete, a lot of things have been changed. And newer guidelines are there, so these RCTs are not keeping up pace with that changing paradigm. Again, we have a global urgency. The population of diabetics worldwide is 537 million. In India, we have 103 million people with diabetes and 125 million with pre-diabetes. So we can see a huge gap between research and patient our need. Development gap we have already talked, and because of this tedious and long duration, research saturation is there. For example, GLP and GIP based therapy are the newer thing in market, and their research is already saturated by 2025, and that is only at the level of 16.4%. Now, what is the problem with this randomized controlled trials? They exclude many of the patients that we see in our clinical practice. For example, any patient having comorbidity, any patient having polypharmacy, they are excluded. And that is a very huge number. About 60 to 70% of the real patients that we are treating in our OPD setup, they are excluded. Again, representation gap is there, because most of these trials are funded by US company, are studied in Western population. So our population, they are underrepresented. Some minority population, they are underrepresented. And again, there is two terms, efficacy versus effectiveness. Minded efficacy is always talked in controlled randomized trials in a very idealized condition. But when we talk about real world scenario, the thing is completely different. That we'll see in further slides. If we try to take adaptive design and pragmatic design, we can reduce the time and cost by as much as 20 to 30%. That we can see what impact it can drug for newer drug development. Again, most of the earlier randomized controlled trials, their endpoint was very similar. For example, all trials we talked about UK, PDS, DCCT, they all have talked about a single endpoint, that is HbA1c. And what was not covered in that trial was that beyond glycemia we have multiple things. We should talk about risk of hypoglycemia, quality of life, what is the glycemic variability, what is the time in range that patient is having good glycemic control, and what is the patient bias. In all randomized control trials, there was no room for patient bias. What is the treatment satisfaction and what is the diabetes distress, that was not being addressed in typical trials. So in these all newer trials, these things should be incalculated. Again, we have multiple drugs which have many pathophysiology. For example, SGLT2 inhibitors, when they came into market, they were a drug of endocrinologists, then they become drug of nephrologists, and now they have become a drug for cardiologists. So we can see that how rapidly these things are evolving. Similar goes with newer drugs like GLP-1 receptor agonist, GLP-1, GIP agonist, that is tirzepatide, NSMRA, finerenone is a new phenomena. So we can see any trials who try to cover all these things and not a single endpoint. Coming to the landscape of trials, in diabetic trial, when we see, as we can see, it is dominated predominantly by US company. About 30% is US company. There is rapid change recently, and China is taking lead. Again, there is a monopoly of single company, and Novo Nordisk research team, as we can see, they have invested around 5 billion in 2023. So we can see there is huge monopoly. What is opportunity here? Because we Indians have a very high, very good number of diabetes. We have 103 million people having diabetes. We have very good human resource. And just taking adaptive design, we can be the center stage of diabetes development globally. Coming to the adaptive designs, how we can optimize trials in real time. Adaptive trials modify protocols based on accumulating evidence. They have some pre-specified rules such as dose modification, sample size re-estimation, early stocking. They all are planned in advance. And depending upon the interim analysis, that can be modified. Again, this modification doesn't compromise the trial integrity and the type 1 error. It means if type 1 error goes on increasing, then we have to refute that protocol. And for that we have regulatory framework. We have FDA and European Medical Agency 2019 guidelines for the adaptive trial designing. We'll just take some examples of the same. Tirzepatide, that is Monjaro, it was initially started with a single allocated arm of 5 mg. When interim analysis shown that again 5 mg and 10 mg each effective, then that dose was escalated to 15 mg. Then what was the difference? They have a seamless transition, and that eliminated about 20 to 80 months of the treatment duration. Result was that this drug was submitted 18 months before the real estimated trial. Again, coming to the some more trial, that is a stem cell therapy for type 1 diabetes reversal, and in that adaptation was made for safety monitoring. They have proposed multiple cohorts. In first cohort, what they have done, they have started with low dose of stem cell therapy, and they have done intensive monitoring for side effect. If there was no side effect, they moved to cohort 2, where they had intermediate dose with adaptive immunosuppression. Again, they have escalated the dose in cohort 3 with adaptive immunosuppression, and once there was reversal of diabetes, the requirement of insulin became 0. Then what they did, there was rapid trigger involvement. So we can see that how we can, in a continuum, we can increase these trials. Same goes for GLP-1 receptor, CVOT trials. In randomization, they have tried to randomize those patients preferably, those who have high CV risks. As we have discussed, this adaptive design reduces time frame by 20 to 30%. Coming to the pragmatic designs, bringing trials to real world practice. What was the pitfall of RCT that we are trying to circumvent in this pragmatic trial? For example, pragmatic trials, they prioritize external validity, and they have broad inclusion criteria. For example, any patient having elderly comorbidity, they are welcome that you should be enrolled in this study. And they don't do anything. Apart from a standard of care, minimal procedure is carried out, and relevant outcome is measured under usual practicing conditions, not in idealized research settings. Now that is for AID, that is insulin pump, same thing goes here. What is the difference? When we see, as we have talked about one drug, that is GLP-1 agonist, when we talk about GLP-1 drug, that HbA1c was, in that RCT was 1.5%. That is a very huge number, and adherence was 95%. But when real world study was taken, it was shown that it was only effective, efficacy is only about 0.8%, with a drop out rate of 40%. That is a huge number, and that thing is not being covered in RCT. Again, this decentralization trial leverage CGM and timelines. We can collect data from remote location. We can circumvent the geographical problem as we can assess the data remotely without the need of clinic visit. Now, the Dutch pragmatic trial answers all our questions. For example, in pragmatic trials, we can assess effectiveness. We can identify barriers. What are the barriers? And these barriers could be cost concern, could be injection frequency, or not fitting in their lifestyle. And after that, we can formulate some guidelines. That again will be a guiding pillar for formulation national-wide guidelines. Now coming to the take-home message. Now it's a crisis point where we need some newer adaptive designs so that traditional RCTs are not fit and not meeting our purposes. And we have a very good efficiency gain of about 20 to 30%. Real world validity is very high, and by applying a hybrid approach, we can maximize all these outputs. And in all cases of diabetic mellitus, we should look beyond HbA1c. We have to talk about quality of life and other aspects of the diabetes. That was all from my side. You all have been wonderful listeners. Thank you all.
Very good presentation by Dr. Angad on the futures of diabetic trials. Now I invite the next speaker, Abhishek Kamendo. To discuss on diabetes workup beyond glucose.
Thank you, Chairpersons, and my dear esteemed audience. The topic given to me is how to work up beyond glucose in diabetes management, as well as in what are the recent advances. So the topic is very vast. So to conclude in 10 minutes, I will be just giving you the overview. So before I start, why do we need this? Historically, diabetes was considered to be just limited to glucose. We were treating it as a number which should be controlled. Sugar को इस level पे लेके आना है, everything will be fine. But due to recent advances and all the guidelines given by India and other bodies, we have still not managed to control this disease. So the shift is from not only to control the glucose level, but to treat its complication as well as individualized therapy. So we have now to treat not just the glucose, we have to treat it as a toxin. It's not it's a per se, not toxin, because its effects are even there when it's being lowered. So coming to the burden, we know that diabetes is silent killer. It has more complications like CKD, CVD. So when we control, when we focus on only the glucose level, our focus shifts from only to the glucose. We don't more give the credits to the CVD, CKD and dyslipidemia. So we have now more focusing on this complication. So controlling of glucose level will not per se will have this unit, it has so, but we have to focus also on the management of CVD, CKD and other dyslipidemia. So we have a holistic care we have to take about the patients, and we have to individualize the treatment. No blanket treatment can be given for diabetes. Every patient is unique and we have to individualize the therapy. So coming from glucose-centric model to cardiovascular, kidney, metabolic CKM model. So there are changes in diagnostic and therapeutic strategies as we have moving beyond glucose. But just one thing, glucose is not just be a number. rather it should be recognized as a toxin which has a long-term effect. Even if we lower glucose in the long term, the damage it has done should be also considered. This is the main diagnostic work of we used till now. It's given by ADA. So still traditional markers like the RBS level, HbA1c and FBA fasting and PPBS are still there. So I'm not concerned with that. After that, there are some still gap areas. What are that? We are, as a general practitioner, we are not focusing on subtyping of the diabetes. That's why I said earlier, every diabetes patient has to be individualized. It's easier said than done. We have a resource limited setup, but at least we should try. And second thing is focusing on the comorbidities and complications at the time of treating the diabetes. So just sugar पे focus करके अच्छा ठीक है, we have got it near normal, HbA1c हमने control कर लिया, we are losing our focus for that complications. So what we can do now is move beyond glucose-centric metrics. And like glucose-centric, which like all HbA1c, whatever we do is all centered around glucose. And now more focus is being given on metabolomics, genomics, and incorporation of digital health means that we have to use our technology, AI as we know, in programming a treatment for any individual. HbA1c was and still the best indicator, but we have considered as a lagging indicator. जब हमारे पास 10-11 को लेके आता है, damage has already been done. Now we start focusing that we have to control the HbA1c. So now we have shifted from lagging HbA1c, we should go for CGM, the continuous glucose monitoring, so that this lagging and will be reduced and the chances of complication will be reduced. So there are some other biomarkers which are emerging like fructosamine level and glycated albumin. Like HbA1c, we have 120 days framework. This, since the albumin half-life is around 20 days, short-term control, rather short-term guidance it will give. How much was the short-term control? Other factors are like adiponectin, ceramides. They are more organ-specific, and this should be educated. So I showed that fructosamine glycosylated albumin, they have a 2 to 3 weeks control they give, and HbA1c give for around 120 days. So for short-term control, we can go for these markers. The other markers are C-peptide levels, microRNAs, 1,5-nano-glucose, and these are markers. But incorporating, the main factor is how we use this in our clinical practice, because we have a very cost-limited setups. So this thing will take time and to come in practice, day-to-day practice. So, and coming to the future directions, like I said, the more glucose-centric. Now we have two things: this continuous glucose monitoring. We have time in tight range and time in range. So we are, rather than focusing on RBS or fasting PP, these monitoring system which actually say how much time we are spending or how much the patient is having tight control, and whereas tight range and time in range. Tight range में वो थोड़े gap और कम कर लिया है. The patient who spends more time in tight range will have a good prognosis. Other thing is genetic testing. We probably don't do it on random basis, and but still it has to be educated. Why? Because type 1 diabetes, 1.5 diabetes, or type 2 diabetes, and other forms of genetic diabetes. Drug usage. something like MODY3, which is sensitive to sulfonylurea. We can diagnose MODY3 by these genetic makeups. We can target therapy, sulfonylureas can be used. Now coming to the functional testing of insulin. There are clamp techniques and other HOMA-IR and Medusa index which use the functional testing of the insulin which should be used in clinical practice. Coming to the biomarkers of the imaging, like ectopic fat, liver fat. For this MRI, ultrasound and fibroscans are there. For cardio and renal assessment, we have the CT angio, calcium scoring system, echocardiography, which will help in avoiding the CKD or CVD index. For imaging, we have one score FIB-4 index, which it doesn't require any imaging modality, but can be calculated from the blood also. If a FIB-4 index is abnormal, we go for the ELF test or then the fibroscan. So what are the key recommendations now? It should not only be the drugs. One has to take the lifestyle modification, individualized glycemic control and weight loss, regular assessment of his treatment, the priority of which medication he has to take, and every other thing. So still the main control is lifestyle. First we go for the lifestyle, and as previous speaker has also said, remission. This lifestyle modifications have a power for the remissions of disease in pre-diabetics as well as stage diabetes, as if we have pre-diabetes basically. Intensive lifestyle modifications can delay or prevent type 2D onset, improve glycemic controls, and reduces medication needs and can induce remissions. Of this, one thing is very sleep.
2 more minutes.
Sleep duration is for at least for 6 to 9 hours per night, and screening of sleep disorders is advised now. Good sleep versus not good sleep. This is the targets which are given by the ADA. CVDs, now we know the CVD is the most one of the deadliest complication. We have to use the drug which can manage both the decrease the CVD risk as well as the control diabetes. These are the various targets that are given. I will not go into the details. The BP control, anti-platelet therapy, prevention and smoking cessation, weight management, all are there to reduce the CVD risk. Coming to CKD risk decrease, annual assessment of USER as well as eGFR is necessary, and the use of drugs like SGLT2 inhibitors, GLP-1 antagonists, MRS like phenylalanine, and lifestyle modification are key intervention strategies that will reduce the chances of having a patient CKD. Lipid and blood control strategies are every statin therapy, every high-risk patient should have a statin as a primary prevention, and chances of decreasing his CVD and CKD. BP, the target is 130, should be less than 130 and 80. And for the CKD, we are most commonly used drug is acetaminophen. These things are no more increase psychological stress burden and depression. They have to be managed more effectively now, and the patient has to be treated as a whole, not only for diabetes. Thank you. These are my
Thank you, Abhishek. Very good talk on diabetes workup beyond glucose. Now, I shall.
Questions?
Any questions from audience?
I have one question for Dr. Angad. How do you see confounding variables and their roles in adaptive trial design?
again could be a reason as you have discussed. But for that again we talk this in adaptive design. Again the primary thing is that the statistical power of the activity should not go, type 1 error should not increase. That is always in the mind. So whatever adaptation we do, two things, that criteria should be met up. अगर वो fulfill नहीं होता है, then we have to defeat that proposal.
And one question to Dr. Abhishek. My question is that in your clinical practice, suppose a elderly patient comes to you with a CKD, which is the best screening method you use in this patient?
For screening for this CKD patient, we have to manage both his blood pressure as well as sugar, sir. Asymptomatic patient still we have who is not diagnosed of CKD till now, elderly patient, we have still we are using UCR.
EGFR.
EGFR and gluten ratio, sir.
No. I think that he is a diabetic and is suffering from CKD. But you have to screen for diabetes. Which is the best screen?
For diabetes.
For diabetes.
We have a CKD patient, we have to screen for diabetes. We can, since he is, I think HbA1c will be more, because if we go for glycated albumin which is being lost, so it will not give a clear picture. So in my opinion, traditional marker which we are using like HbA1c will hold good. If his anemia is in well controlled, he or she is not having anemia till now, that time.
I would like to add one more thing. We can go for C-peptide along with HbA1c in the elderly group.
And recently you have discussed the fructosamine.
Fructosamine, sir.
And this is also a good criteria to determine the diabetes in CKD. Thank you.
Session.
Thank you everyone. This was a really great presentation by all the speakers, and also we will now facilitate the speakers and respected chairpersons. So kindly chairpersons come here. Dr. Abhay Chaudhary, Dr. Nikhil Goyal, Dr. Indru, please. Also the speakers kindly come here. Dr. Dharmendra Singh, Dr. Angad Kumar, Dr. Abhishek Kamal.
मैम और थोड़ा उधर से बस
डॉक्टर धर्मेंद्र
Dr. Angad Kumar sir. Dr. Abhishek Kamal sir. चैतन्य प्रकाश सर.
अभी खत्म हो गया एक छोटा एचडी निकालना छोटा
Dr. Nikhil sir.
Dr. Kundu Prasad, ma'am. All of you are requested to please kindly join us in the hall 1.
एक ग्रुप फोटोग्राफ ले लो. पेपर मैम इधर आए और इधर आए बहुत जल्दी सर.
And without wasting very much time, I would like to call upon our first moderator for the afternoon, Dr. Adnan Imam sir, to have a good discussion on the topic of hypoglycemia. Over to you, Dr. Imam sir.
Good afternoon everyone, it's our post lunch session, so I hope everybody will be like listening to us. That's an important part.
Nobody will having hypoglycemia.
Nobody will be having hypoglycemia, that's true. So today we are having this panel discussion in view of hypoglycemia, its understanding and managing and preventing it. So we have the panelists, and I will call the panelists number one to please take their seat. Dr. Amitabh Banka sir, who is consultant Mediversal Super Specialty Hospital Patna. Dr. Kamlesh Kumar sir from Gaya, Dr. Mahendra Pratap sir from Sasaram, and Dr. Pushparaj Anand from NSMCH Beta. Dr. Absar has not been able to join us due to some official sudden work that came in, so we have this will be taken care by Dr. Angan Kumar, DM Endocardiology. And then we have Dr. Indu Prasad ma'am, she is an associate professor, BMIMS Powerful. So I welcome all the panelists, and I'll be happy to enlighten by their comments being the panelists of this session. So the panel topics will be regarding the definition and classification of hypoglycemia with detection of vulnerable groups, how to manage that, what's the fear of insulin versus oral hypoglycemic agents, and insulin versus oral hypoglycemic agents, what's the difference between them, and the prevention strategies we will take care of. So the first thing to Dr. Amitabh sir, that how do we define and categorize hypoglycemia in diabetes today?
Thank you, Dr. Adnan, for this question. Hypoglycemia is usually defined as abnormally low blood sugar levels. Initially, we had Whipple's triad, which was a triad in which it was symptom-based definition. in which the first was the symptoms associated with hypoglycemia. Patient should have a symptom associated with hypoglycemia. Patient should have a documented blood sugar low levels. And third was the relief of the symptoms of hypoglycemia after the treatment of hypoglycemia. So this was for a long time, and we still can use this for a definition of hypoglycemia. Later, the numeric glucose thresholds have come for the more standardized cutoffs and for safety and research. And now ADA describes hypoglycemia in 3 levels: level 1, level 2, level 3. Level 1 is one when we have a blood sugar level less than 70 milligram per deciliter. Level 2 is when we have less than 54. And level 3 is where there is an altered mental status or a physical status requiring third-party help. But in general, we can define hypoglycemia as less than 70 for non-diabetic patients, pregnant patients, and elderly age group patients, and 54 as a cutoff for the diabetic patients.
So that's very true what sir has told, and in our clinical practice as well, sometimes the patients come to our OPD and say, sir, I had tremors and all, but sometimes I feel I'm not feeling good, but my blood sugar levels are 100 when I checked at that time. So we cannot say hypoglycemia exactly at that moment until unless we tell them that if it goes below 70, there may be something else that we need to find out. So sometimes cutoff marking very much helpful to go for the tag of hypoglycemia or not. So my second question is to Dr. Kamlesh sir. How can we detect hypoglycemia early? That's an important, because you know what happens, and identify patient with hypoglycemic unawareness.
Okay, thank you, Edna. Now first, why early? As we all know, hypoglycemia means blood sugar less than 70 or 3.9 AG1. So by diagnosing hypoglycemia early, we can save the patient for going in severe hypoglycemic state. So diminish the rate of admission and save the safety profile. So hypoglycemia, it can be diagnosed by symptomatic symptoms or some regulation. Symptoms like common symptoms are neuroglycemic symptoms like confusion, difficulty in concentration and slurring of the speech, and specific for symptoms due to epinephrine, that is palpitation, anxiety, tremor, and cholinergic symptoms, that is sweating, hunger, and paresthesia. So diagnosis on the basis of clinical feature and some lab diagnosis, mainly by continuous blood sugar monitoring. Sugar monitoring before meal, before bedtime, and during sleep. Yes. Second one is unawareness. Hypoglycemia, unawareness means patient is in hypoglycemic state, but he is not aware of hypoglycemia, and so he can run up into the severe hypoglycemic state. Unawareness, we can diagnose by a gold standard score. It's a name itself, gold score means only by one question to the patient. Do you know when your hypoglycemia starts? If a patient says always, it's a score 1, usually a score 2. If he says sometime, means a score 3, and if its answer is never, means score 4. So a score 3 and more is a state of hypoglycemia unawareness. So gold standard method is gold study, and other method is by Clark questionnaire, means detailed assessment of the symptomatic process. So our take-home message is early detection and systematic screening gives better outcome and safe treatment.
That's true, sir. So the crunch of the all of the thing is the early detection will always save the patient from any further damage to the body, and the patient may not line up into other complications with respect to hypoglycemia. So that's great, sir, that what you have provided this good score is also a good point to be noted. So this question is for Dr. Mahendra, sir. Step-wise management of hypoglycemia, how do we proceed actually?
Yes, now we will proceed towards the stepwise management of hypoglycemia. We will first diagnose the patient that the hypoglycemia falls in the category of mild hypoglycemia or moderate, or it is a severe type of hypoglycemia. Once the patient has been identified and if he is conscious, once the patient is conscious, he can be categorized as mild, moderate to moderate hypoglycemia. So we follow the 15-15 rule. Means we have to give 15 gram of fast carbs like glucose candies and fruit juices. Then we have to wait for 15 minutes. Then we have to recheck the blood glucose. And if it is still less than 70 mg per dl, as we know in diabetic 54 mg per dl is the hypoglycemic level. It is if it is less than 70 mg per dl, then we will repeat the same protocol for 1 to 3 times. And thereafter, once it is more than 100 milligram per dl, then we give complex carbs, not fast carbs, with some protein, not fats. This protocol almost signifies that the patient don't have rebound hyperglycemia if we are repeatedly giving a large amount of fast carbs. Therefore, it has been said that after the glucose level reaches 100, we have to give complex carbs which will release the sugar slowly, and then with protein, not fats. Because due to fast carbohydrates, the glucose levels rises quickly every 15 minutes. We are giving already, and there should not be over treatment of the patient. So, key points in managing the mild to moderate hypoglycemia patients is to avoid high fat foods. We have to be alert that the patient, if he is proceeding towards moderate to severe hypoglycemia, so he should swallow the food items safely, and we have to recheck every 15 minutes. Now coming towards the unconscious state of severe hypoglycemia, where blood glucose is less than 54 and the patient becomes unconscious, there is neurological symptoms appear. We have two protocols in that. Either the patient may be at home, or the patient has reached the emergency of an hospital. If the patient is at home, glucagon is the best choice. We have to give glucagon, which is available in standard intramuscular or subcutaneous doses, or easily available, not very much hassle containing, that intranasal spray which contains 3 mg. It is also needle-free things, and we give glucagon. We wait for 5 to 15 minutes and then recheck. Once the patient is alert, then we give fast carbs plus complex carbs. If the patient has already reached the hospital, then intravenous dextrose is the best option, followed by continuous infusion of dextrose if required. So in case of emergencies, the patient has to. Now coming to the prevention and long-term strategy, when we talk of, so we have to think of the physiology and integrate it with technology, and thereby releasing the reconsidering the pharmacology of treatment of hypoglycemia. So hypoglycemia associated autonomic failure, that is when the patient becomes unconscious or drowsy, or the patient has autonomic symptoms. So it is a vicious cycle. Sir has already told that the patients are actually unaware of their hypoglycemia scores, which is the major cause. Because the patient who is persistently going in hypoglycemia due to any type of management. So we have 4 populations. One is general diabetic population, which we already have talked. Apart from that, we have 3 special populations in which hypoglycemia occurs. One is the pediatric age group, then there is the geriatric age group, and hypoglycemia in pregnancy. In all the three, we have to manage the hypoglycemia according to their capabilities of age group. Like in pediatrics, we have to use mini dose like 5 to 10 grams of carbs. In geriatric population, there is polypharmacy while treating diabetes, so we have to avoid those. And in pregnancy, we have to think of maternal hyperglycemia or fetal hyperinsulinemia. That's it.
Thank you, sir. Thank you for your enlightenment on this topic. And I think the most important hypoglycemic population out of these will be pediatric population with type 1 diabetes that we always see. And the sweating occurs in the child and sweating occurs in the physician to manage that sometimes. So it's a tough job.
Individualized treatment is required. Individualized protocols like 504 protocol, which we use generally for specialized people or physically debilitated or specialized categories. So such type of protocols should be used in pediatrics.
Thank you, sir. So now, why does insulin causes fear of hypoglycemia? Where we know that every patient says that insulin will cause hypoglycemia, sir, give me tablets. Whereas OHA causing it don't lead to similar fear to the patient. It's a very common question in our clinical practice. I'll ask Dr. Pushparaj Anand sir to put a light on this.
Actually, it's there have been many studies which show that patients or doctors, they generally want to be on oral hypoglycemic agents and they fear getting on insulin. There are n number of reasons behind that. The major cause, what the physicians feel, is that insulin is independent of plasma glucose level. That there is basically no physiological off switch for it. If once the glucose level starts going down, and if you do not intervene on time, there is no coming back of the plasma glucose level, and you can fall very sick. There is a very steep dose response curve to the insulin, and absorption to this in different patient group is very different. It's very unpredictable. It generally causes very severe nocturnal hypoglycemic episodes also, due to which patients fall sick and are sometimes remain unconscious, and especially in geriatric populations who are not very ignorant, who are very ignorant about their food and habits and also. And in some physicians also who have faced certain episodes in the patients who have undergone hypoglycemia, they are also very reluctant in using insulins, and they are not as much as reluctant in using OHAs. When we are talking about oral hypoglycemic agents, rather if we leave out sulfonylureas, most of the OHAs, they act on a glucose dependent manner. They have that physiological safety switch in them, and if the hypoglycemia occurs also in these group of patients, it's very usually mild and self-correctable. Overall, we have seen that if we give an option of tablet or an injection to any person, it's a psychological mindset that the patient will try to take tablets before taking injection. It's psychologically considered safe. The tablets are considered safe as compared to the injections. So that is one of the another reason why OHA has less fear. Another thing, we talked about severity. If patient goes into a hypoglycemic attack, insulin also, it's we have to there is very mild hypoglycemic attack in OHA. Where in insulin, it's not that mild and it often leads to severe symptoms. So thus adherence also is very better in OHAs and is less adherent in insulin, I guess.
So that's right, that's totally true. One of the most important point is also like counseling the patient correctly, because we have now newer insulins also which causes low risk of hypoglycemia when we are not giving it with insulin secretagogues. So it will actually cause very low risk of hypoglycemia, but the thing, it has to be counseled. We need to give patient some time. We have special molecules DPP-4 inhibitors with this low risk of hypoglycemic insulins these days. So I think giving some time to the patient with a proper counseling regarding this may help the patient to prevent it with respect to this fear of hypoglycemia from tablets and insulin. Right. So this was the crunch from Dr. Pushparaj sir. Now, so Dr. Absar is not here, so we have a slide, and Dr. Angad, endocrinologist, Dr. Patna will be answering this, that which therapies most often lead to distress due to hypoglycemia, and how do we actually address that?
Okay. When we talk about hypoglycemia in those individuals who are diabetic, it's a different ballgame. In those patients who are diabetic, they have either insulin or insulin secretory. Again, we have to understand, older the generation of insulin, higher the risk of hypoglycemia. Once we have started with porcine insulin, then come human insulin. These insulins have very high risk of hypoglycemia because of the packing effect and everything. But newer generation, insulin analogs, they have virtually lesser risk of hypoglycemia. Same goes with basal insulin. With NPH, with determined risk of hypoglycemia is very high. But newer generation, true basal insulin, whether we talk about insulin, Glargine, U300, or we talk about insulin degludec, risk of hypoglycemia is lesser. Among drugs, sulfonylurea and any type of insulin secretagogues, they will lead to higher risk of hypoglycemia. In sulfonylurea, previous generation sulfonylurea such as glibenclamide, glipizide, they have higher risk of hypoglycemia. Newer generation sulfonylurea, gliclazide, they have lesser risk of hypoglycemia. Again, with other molecules such as netaglinide, repaglinide, they have risk of hypoglycemia. This is one thing, how we can address this problem. So, if the patient is having a recurrent hypoglycemia, we have to reduce the dose of insulin. If you are trying to initiate any therapy that has very good hypoglycemic effect, for example, it could be SGLT2 inhibitors, GLP-based therapy, tirzepatide, then ideally you have to reduce the dose. Insulin dose should be reduced by 30%, VHA dose should be reduced by 50%. And that was drugs causing hypoglycemia in diabetic. I am, being an endocrinologist, I am more concerned about drugs that is not in non-diabetic patient. So there is a list of drugs that cause hypoglycemia in non-diabetic individuals and molecules that may look very innocent. For example, alpha lipoic acid. हमारे सबके prescription में alpha lipoic acid is a very common ingredient, and we have seen a case where we have done everything. We have done genetic analysis, we have done insulin antibody, and when we diligently searched, the reason for hypoglycemia was that alpha lipoic acid. So we don't have to forget the few drugs such as alpha lipoic acid, methinate, dioxide, minoxidil, phenytoin, ciprofloxacin, they can also cause hypoglycemia. Thank you.
So the last point was the most important part, that few drugs which we are giving non-diabetic as well as diabetic patients also, that may also cause hypoglycemia resistant. Thank you Dr. Agat for such a enlightening answer for this question to us. Now the last part is the prevention part that we always talk about in diabetes, but it should come first. The prevention is first with respect to medication. So what practical steps can be taken to minimize the hypoglycemic episodes in daily clinical practice? So Dr. Indu ma'am will address this topic.
Thank you, Dr. Adnan. Hypoglycemia, it remains one of the most common but yet preventable complications of diabetes management. While achieving good glycemic control is essential, but it should never be done at the cost of patient safety. So the cornerstone in this prevention is individualizing the glycemic targets. Young, healthy adults with recent type 1 can be targeted A1C level up to or less than 7% if achievable without the significant hypoglycemia, and individualized targets should be tailored for higher HbA1c goals like 7.5 to 8.5% for older adults who have the limited life expectancy, severe comorbidities and severe episodes of hypos. Renal dose adjustments should be done in patients with eGFR less than 60 ml per minute per 1.73 meters square, and hospitalized patient, the blood sugar level should be targeted within the range of 140 to 180 milligram per dl, and sick day protocols should not be forgotten. And second is we should choose the low glycemic drugs. We must choose the glycemic therapy very wisely. We should go for low risk drugs like metformin, TPP4, SGLT and GLP-1 analogs, and never should over-treat the patient with inappropriate insulin intensification. And patient and family education is crucial regarding recognizing the hypoglycemic symptoms. Importance of consistent meal times, carbohydrate intake, in between meal, bedtime snacking, when patient is on insulin especially, adjusting the medication, snacks for who is doing exercise or having alcohol consumption. And very important is the carrying some medical identification like bracelets or tags, and such patient who are at the risk of hypoglycemia must carry some form of simple sugars at all the time with them so as to combat immediately the hypoglycemia. And the use of CGM and SMBG can help in early detection and timely correction of the falling blood glucose levels. We can have CGM with alert systems. Proper SMBG is very important. Real-time data, trend arrows like that, and alarms who provide visual and acoustic alerts when glucose levels drop below a reset low threshold. So, preventing hypoglycemia is a true measure for the successful diabetes care.
Thank you, ma'am. So what we got from this is like, I always tell to my patients that there should be a thermostat in the diabetes management, which was not there previously, as sulfonylurea was one of the major role in playing molecule. But in today's market, now DPP4 and sulfonylurea, they don't have a very much of cost difference in between them. So we can use the molecule which works as a thermostat and don't allow the patient to go into hypos. And this is one of the important things. The best part is the use of CGM devices if somebody can afford, what ma'am have told. It's a marvelous thing. Few of my patients are on it, and seriously they check it and they think that if they have low hypo, they eat something more, they eat something good. And if their blood sugars are at the above side pre-meals, they eat a meal which is good in proteins, not carbs. So it is very much helping in maintaining that TIR as well as helping the patient to prevent the hypoglycemic episodes during throughout the day. So if affordability is not an issue, CGM is one of the best devices that can help you to prevent hyper as well as hypos. So that was a great panel discussion. If somebody has questions regarding this, you can take up the questions. This means that we were very much clear in our talk and answer. I hope so. So, thank you. Thank you to all my panelists who gave time for this important topic and to throw the light with their comments. So, I will ask Dr. Pushparaj to be with me to give the certificates to our panelists for this. Dr. Devendu sir, can you please come and please hand over the certificate to one of our panelists. Dr. Kamlesh sir. Thank you, sir. May I call Dr. Prakash, yes, Prakash sir, to please hand over the certificate to Dr. Amitabh Manka sir. May I call Dr. Panache Chaudhary? To hand over the certificate to Dr. Mahendra sir. Dr. Mahendra sir, please. Dr. Mahendra has already got in one of the sessions above.
I would like to call upon Dr. Sajjad sir. Dr. Adnan sir.
Thank you. Sorry.
Thank you, Indu ma'am. She has also been facilitated today. Angad and Dr. Indu ma'am has been facilitated today in the morning session. So now the second session after this will be by Dr. Divyendu sir, I think. Thank you.
I would like to call upon the stage Dr. Divyendu Bhushan sir to carry out the next panel discussion on the topic of diabetic ketoacidosis. So please welcome on the stage, sir.
Thank you, Dr. Pushpal. First of all, I am thankful to the organizers, Dr. Vijay sir, Dr. Mukherjee sir, Dr. Sadar Boha, for inviting me for this panel discussion. Now, so when we talk about diabetes, the complications of diabetes, the first thing that which a MD graduates learn in his career, and decay is the foremost complication with which the type 1 diabetes present to the in the emergency. So for this discussion of today's of decay, I would like to invite our panelists. The first is Dr. Santosh Nayan. Please welcome Dr. Santosh Nayan from the Associate Professor in the Department of Emergency Medicine in IGMS Patna. Dr. Anand Dev is also Associate Professor in Critical Care Medicine, IGMS Patna. I invite Dr. Sanjeev Kumar, he is Assistant Professor in Department of Internal Medicine at AIIMS Patna. Dr. Sunil Kumar is Assistant Professor in Department of Emergency Medicine at AIIMS Patna. And Dr. Ashok Kumar Agarwal, he is Consultant in Internal Medicine in Jayaprabha Vedanta Hospital. So welcome all the panelists. So this is a panel discussion, and I would like if any other faculty wants to discuss their experience, they can freely do it in this panel discussion. So let's move on. It is diabetic ketoacidosis. It is a life-threatening complication, as we all know. It usually found in the type 1 diabetes in classical way, but it can occur in type 2 diabetes also, and it is quite frequent. It can, the patient, although the mortality has decreased now, but still the pediatric population usually suffer from this, and they can cause mortality too if it is not recognized or it is not treated on the time. So what is the definition? So any one of you like to define the diabetic ketoacidosis?
Yeah, thank you for giving the opportunity. As per classical diabetic ketoacidosis, there must be hyperglycemia. Initially, for classical decay cutoff was 250, but now due to the rising trend of use of SGLT2 inhibitor, we must keep the cutoff within normal range or near normal. So three parameters should be there: hyperglycemia, ketosis and metabolic acidosis.
So very correctly said by Dr. Agrawal that earlier the cutoff was 250 or 300. Now it is put it down by the ADA that it can be taken above the level of 200 because of the introduction of the entity which is called euglycemic decay. And ketosis, as we can see that beta hydroxybutyrate level, it is preferred in the urine. If it is more than 3 millimole per liter, then it is one of the criteria. And metabolic acidosis, that is pH less than 7.3 and bicarbonate less than 18. So these are the defining criteria for decay. So many times we don't even see the classical things that very quite high the blood sugar, ketones are raised in the urine, it is typically it comes 3, 4 or 4 plus, or metabolic acidosis. When the patient comes from some other hospital, that sugar may be within the range also. So these are the spectrum. Now classification. So I would like to ask Dr. Agrawal and Dr. Sunil that how we will make the diagnosis in the emergency. Dr. Sunil, it will be appropriate for you.
Good afternoon, everyone. If any diabetic patient comes in emergency or visit any physician with a complaint of nausea, vomiting, pain abdomen, shortness of breath, with certain signs like hypotension, tachycardia, small breathing, then a physician must have suspect decay in that patient. The diagnostic criteria for decay is well defined. That is, patient should have hyperglycemia, that is, RBS must be greater than 200 mg per dl, and there must be ketone body, especially beta hydroxybutyrate, that is more than 3 millimole per liter, and apart from it, the metabolic acidosis should be there, that is pH must be less than 7.3 and bicarb is less than 80. As far as severity is concerned, it can be classified as mild decay, moderate and severe decay. In mild one, the glucose is more than 200, in moderate the glucose is 200, but in severe decay, glucose is more than 200, and in ketone body beta hydroxybutyrate level, in mild and moderate case, there must be 3 to 6 millimole per liter, but in severe case, it should be greater than 6 millimole per liter. As acidosis is concerned, in mild cases, pH is between 7.25 to 7.3, and in moderate 7.0 to 7.25, and in severe case, pH is very less, that is less than 7. Bicarbonate level, in severe case, it should be less than 10. In moderate case, it is in between 10 to 15, and in mild case, it is 15 to 18. As far as mental status is concerned, in severe decay, patient lands in a stuporous condition of comatose patient. In moderate, patient may be alert, and in mild one, patient is alert. And suggested level of care in mild decay is regular ward observation, and in severe decay, intensive care unit or ICU care must be there for the infusion of insulin and fluid resuscitation.
Thank you, Dr. Sunil. I would like to ask Dr. Anand, he is experienced in the IGIMS. How you diagnose in the emergency the decay patients, and how you start treatment on those cases?
Thank you, sir, for giving me the opportunity, and good evening, everyone. The treatment goal of the diabetic ketoacidosis is basically on the starting of the fluid therapy, insulin therapy, electrolyte condition of the patient, especially the potassium, identifying the precipitating cause, and the careful monitoring. These are the 5 goals which we have to maintain. The first which we have to do is the fluid therapy. The starting fluid therapy must be at the rate of bolus fluid therapy must be given to the patient with at the rate of 15 to 20 ml per kg, and the preferred fluid is the 0.9 ns. But the choice of the fluid can be changed according to some of the studies which have been seen that the ringer lactate can also be done. And the electrolyte state also defines which food we have to take. If the sodium level crosses more than 150, then the 0.45 ms is the preferred one. And if hyperchloremia is present, then ringer lactate can be preferred. And if the glucose level falls below the 200, then the glucose infusion has to be started. Subsequently, after the bolus dose, the subsequent fluid therapy depends on the status of the patient, and it has to be monitored carefully. If we infuse too much of fluid, then that can lead to the ARDS and the other complications, and too less of the fluid will lead to the hypotension. Second important aspect in the management of the DKA is the insulin therapy. The insulin dose is the 0.1 unit per kg is the starting loading dose. Is the starting dose of the DKA. Earlier the loading dose was preferred, but the studies have shown that there is no role of this bolus dose. So the starting dose is given at the rate of 0.1 unit per kg per hour, and the target fall is the 50 to 75 milligram per dl is the fall at which we have preferred it. And before stopping the insulin, there are the few criteria. The acidosis must be improved and the bicarbonate level must increase above the 50. That is the criteria, and before stopping the insulin, the subcutaneous dose has to be overlapped. The long-acting insulin must be preferred 3 hours before the stopping the infusion, and the bolus insulin must be given with the first meal of the patient. So these are the two main things, and before starting insulin therapy, the potassium level has to be assessed. Potassium is very tricky in the management of DKA because increased urine output, vomiting, the acidosis and the use of the insulin is the levels which affect the potassium level. If the potassium level is less than 3.5, then the insulin therapy has to be withheld before raising the insulin in the potassium level. Potassium level in that condition must be improved, and subsequently the insulin therapy must be started. Once the insulin has been started, then we have to look at the potassium level at every 2 hours, and it has to be adjusted in between the 3.5 to 5.5 milligram per dl. It has to be maintained. 3.5 to 4.5, this potassium level has to be maintained. Other electrolytes are also very important, like magnesium is also always correlated with the potassium and is also found low in some of the cases of DKA. So magnesium level has to be corrected. Phosphate and bicarbonate are not routinely corrected in DKA. Bicarbonate are only corrected when there is a severe acidosis, the pH is less than 7, and phosphate is also corrected only in diabetic cases only. Now the main important point is the diagnosis of the precipitating factor. There are usually the 5 I's which are responsible for the precipitation, that is the infection, infarction, inadequate insulin dose, and these intoxications like cocaine and some other drugs. These are the important precipitating factors. Identification and appropriate treatment of these precipitating factors are very important. But the most important part in the management of decay is the monitoring. Monitoring is the main thing which has to be monitored. When to start the therapy and when to switch over to the other therapies, it is the main thing which is responsible for the better outcome of the patient.
Yeah, thank you, Dr. Sandeep. So you have really summarized the management of diabetic ketoacidosis. The first thing is the fluid, and as he says that it is normal saline and followed by the insulin, where we have to keep in mind about the potassium levels. If it is low, then we have to hold it because insulin make the potassium intracellular. And what the role of ultra short acting insulin in the treatment of DKA? It has not been still proved to be beneficial, overall beneficial, if we replace regular insulin with the ultra short acting insulin. But yes, as Dr. Saab has already stressed upon that, when we shift from IV insulin to the subcutaneous insulin, the early introduction of the long acting insulin is now advocated. So now I would like to know from Dr. Santosh Nain that another major hyperglycemic complication, that is hyperosmolar coma. It is also very common in type 2 diabetes in elderlies, and it has about subacute course of onset. So how the treatment differs when we compare DKA with the HHS?
Good morning, sir.
DKA and HHS both have the spectrums of hyperglycemia, as we know. DKA is basically found in the pediatric group of patients, whereas HHS is seen in elderly group of patients. So HHS is basically characterized by severe hyperglycemia. Usually the glucose level is more than 600 milligrams and resulting into severe osmotic dialysis, leading to severe dehydration of the patient. So this is the basic point in HHS. There is no ketoacidosis. This is the difference between these two. So the management also differs between these two. Though the management of HHS is basically correction of fluid. Sometimes it has been seen that only correction of the fluid can improve the patient. However, the mainstay is correction of the fluid. The fluid should be given similarly to DKA but less vigorous. With 10 to 15 ml per kg per hour infusion is there. If the patient renal and cardio status is normal, then full dose of the fluid can be given. If the patient is compromised with cardio or renal compromise, then the patient fluid therapy should be accordingly adjusted with other measurements for the fluid of the body. Apart from the fluid management, so there is a role of insulin is also there. Hyperglycemia is usually severe, 600, more than 600. So IV insulin therapy is advocated, just as it is advocated in DKA. So the insulin should be given to the patient in bolus as well as continuous infusion rate. The sugar level should be usually maintained at the rate of in the range of 250 to 300 milligrams per day. Third point is the management of electrolyte. In this case, HHS, the important point is that management of potassium is there. Since at the start of the therapy, potassium can be normal, but when we give insulin, hypokalemia is expected. So that should be corrected. So these patients are hypotonic. So there is loss of fluid, and accordingly loss of fluid, also there is loss of sodium. But loss of fluid is much more than the loss of sodium. So there is a state of hypertonicity. The serum sodium may be higher or normal, or it may be higher. So at the start of the fluid therapy, serum osmolality should be always measured. If the serum osmolality is more than 340, then half normal saline should be started. Or if it's less than 340, then normal saline can be started.
So it's very nicely said, Dr. Nair, that the main difference between the DKA and HHS is about the degree of hyperglycemia. And as I have shown here, that it is about the pathophysiology of the DKA and HHS. We can see that why the ketoacidosis precipitate, it is the imbalance of the counter-regulatory hormones, insulin and the glucagon. In type 1 diabetes, the insulin is not there and glucagon is there. So it causes ketoacidosis. It causes the formation of ketones more in the type 1 diabetes. That is why type 2 diabetes patients, when they develop hyperglycemia, they are not able to form the ketone bodies, because in their body the insulin is still there. So this is the pathophysiology mechanism of HHS and the DKA. And as Sir has correctly said, that the level of hyperglycemia is more in the HHS, the fluid deficit is more in the HHS. Classically it is that like in DKA there is the fluid deficit of around 5 to 6 liter. In HSS it is around 12 liter of fluid deficit. So we have, it happens gradually HHS. The DKA happens like today the patient is all well, the one day after it has converted to the full-blown DKA. The HHS takes some acute time. It is developed over the days and the weeks. So the fluid replacement and other things has to be gradual also. Otherwise there is a sudden shift and they can lead to the cerebral edema and other complications. So now we move on to what are the complications and the prevention strategies in the DKA. may I know Dr. Anand to...
Sir, hypoglycemia and hypokalemia, these are by far the most commonest complications during treatment of DKA. Hyperglycemia can also be there because if we stop the insulin without the overlapping subcutaneous insulin, that will lead to hyperglycemia. Now coming to hypokalemia, we all know when we start the insulin treatment, it pushes the potassium inside the cell, that can lead to hypokalemia. Other complications can also be there like hypomagnesemia. Then as we were told that hyperchloremia, this is also a very important complication. In fact, hyperchloremic metabolic acidosis, that is normal anion cap hyperchloremic metabolic acidosis, is almost found in 1/3 of the patients. It should not be rather treated as a complication because it's ongoing process along the course of resolution, and with time this normal anion gap hyperchloremic metabolic acidosis resolves. Now the most important complication, especially in children, pediatric age group, is cerebral edema. We had already discussed cerebral edema. So the mortality in one thing is very important, that it is mostly found in the children, not common in adults, and the mortality rate for cerebral edema is as high as 30%. So precipitating factors for cerebral edema is a very high blood sugar at the time of presentation, high acidosis, then high PaCO2. These are some precipitating factors for cerebral edema. How we can manage the treatment has already been discussed. What's the dose of hypertonic saline, or so it has already been discussed. Then other complications of DKA can be acute renal failure. Then it's a prothrombotic states. Then because of that we can get venous thrombosis also. Rhabdomyolysis, although rare, it can occur. Rhabdomyolysis leading to ERF, and in some very few rare cases myocarditis has been seen. So these are some few complications of DKA, mainly they are treatment related. Now coming to the prevention of this DKA. So for the prevention, both the patient and caregivers, they have to be educated regarding this disease. So what are the factors that can lead to this precipitate, that can lead to DKA? They have to be educated regarding the symptoms like pain abdomen, signs of dehydration. So these, both the patient and the caregivers, they have to be educated regarding that. And very important thing is the sick day rules. So whenever the patient is sick, that is having some infection, pneumonia, dehydration and all those things, then the level of counter-regulatory hormones are more. So in that case, our base rises. So it's very important not to stop the basal insulin in those cases. Okay, so basal insulin has not to be stopped in those sick period. Then hydration has to be maintained. If at all the blood sugar is less than 250, then low carbohydrate diet like diluted juices can be taken. Yes, diluted juices can be taken. So if the sugar is above 250, then corrective supplemental doses of regular insulin can also be taken. There is an NHS chart, sir, if you can project that NHS. This is a sick day rules given by NHS, although this has been given for type 2 diabetes, but it can be applied with some corrective doses and taken into consideration the insulin resistance of the patient. And another very important thing, taken into consideration the SGL2 being taken by the patient, that which is a euglycemic decay. So when we are considering this NHS sick day rules for type 2 diabetes, we have to take care of that. And they have given some values when to take some supplemental corrective regular insulin, like 11 to 17 millimole, you can take to 17 to 20. So these are some rough estimate. These has to be tailored by the patient according to his insulin resistance. Then there are some advices regarding taking hydration, then symptom control, and all those. Then nutritional advices. Then what are the signs and symptoms like this vomiting and all those things. So the patient has to be educated, both the patient and the caregiver, regarding these sick day rules. So very clear, in sick days we do not have to stop the basal insulin at least. patient has to be rehydrated, also carbohydrate they can take depending upon the blood sugar level is 250 less or above the 250. So these things are important in the prevention of leaking.
Very true, Dr. Anil. It is very important, and that explaining sick day rules to the patient, especially to the type 1 diabetic, where we can say that this complication occurs within the hours or in a course of one day only. In those patients, we have to explain them how to check for their ketone bodies also. In type 1 patients, usually we tell them how to measure to keep the urine dipstick with them, and whenever they found that their glucose level goes above that 350, they have to check the urine ketones. And if it is found to be 1 plus or 2 plus, we usually advise them how to tailor their medicines and how to tailor their diet to reduce the acidosis and ketosis. And if it is 3 to 4, we always ask them to visit the nearby hospital to get treatment and to get admitted. So these are the sick day rules which these has to be advocated at every visit. These things we have to emphasize them and their parents in every visit. Otherwise, they just forget and they just ignore the what mistake they did. So by this, we can say that for prevention diabetic ketosis, we have to recognize it early and we have to save the life. The fluid, insulin, and potassium are the pillar of the treatment goals, and always treat the precipitating cause. It happens that once we treat the blood glucose level and when we switch to the subcutaneous, again the sugar goes high and then again the patient will get into the acidosis. It happens quite common. In that cases, early introduction of the basal insulin is very important. And protocolized based treatment. Every institute, every hospital has its own, everything has their own criteria of starting availability of the insulin. They can make their own protocols to treat the decay, and they should do it religiously. So this is all about the decay. And I think if anybody is having any suggestion, then they can put, and if somebody wants to share their experience, the young MDs are here, they can share their experience of treatment of decay. Dr. Divakar, you want to share some experience? You have treated decay or not? How so you can share your experience?
Actually, diagnosing decay at like right time is very important because like patient usually with pain abdomen and sometimes other sensorium. So people are diagnosed with acute pancreatitis, and sometimes the mileage is also elevated. So first thing is you have to suspect decay in somebody even coming with abdominal pain. So first thing is to like suspect it, and then when you suspect it, then of course the treatment part, whatever sir and everybody else has said, is what we do. And actually timely diagnosing it is itself the best thing to be done, and it helps in treating the patient because treatment everybody knows, it's timely diagnosis what is more important.
How many mortalities have you seen in decay?
Yes sir.
How many mortalities you have seen in decay?
There have been mortalities sir. Actually somebody who has been already coming with altered sensorium, they have been intubated, and those patients usually die. Otherwise, most of the patients actually does better as time passes by. With just all these treatments like just fluid therapy and insulin helps them in getting better.
So early recognition, so early recognition and appropriate treatment is the cornerstone of the management of this common complications of type 1 diabetic, and we should be aware of this. And I think this is one of the quality indicators when I ICU that decay should not die. One of the quality indicators we usually follow. And yes, the other complications can happen, and the precipitating cause can kill the patients. So thank you all. Thank you. Thank you.
Thank you, sir, for
Dr. Sanjeev Kumar. Dr. Santosh Nayan. Dr. Anand Dev. Dr. Sunil Kumar. Dr. Ashok Kumar Agarwal.
दूसरों को मौका मिला चाहिए।
तो कुछ लोग उधर आ सकते हैं, ये एरिया नहीं आ रहा। जस्ट आपका
वहाँ कर लीजिए, इधर आ जाइए। कुछ लोग बैठ
कैमरा
डॉक्टर अभिषेक कमेंदु सर, डॉक्टर मनोज सर, डॉक्टर गोविंद प्रसाद सर, डॉक्टर श्यामा मैम, डॉक्टर प्रफुल्ल दीपांकर सर।
पेन चाहिए।
Very good evening to my respected professors and faculties and my colleagues. I am Dr. Advaita Shankar, first year postgraduate from the Department of General Medicine from Lord Buddha Medical College, Saharsa. Today I am going to be presenting on the topic of mononeuritis multiplex. Mononeuritis multiplex is a nerve disorder which is characterized by damage of at least 2 peripheral nerves at different sides of the body, leading to asymmetrical motor and sensory deficits. The accumulation of multiple mononeuropathies is collectively termed as mononeuritis multiplex. There can be various multiple causative factors leading to this pattern of nerve damage. In this discussion, we will focus primarily on one of the most common metabolic causes of mononeuritis multiplex, that's diabetes mellitus. So this can be divided into, the causative factors can be divided primarily into 2 types, compressive and non-compressive type causes. Under compressive causes, it mainly, there are 2 types, that is due to tumors or due to presence of fractures. And under non-compressive causes, it can be various metabolic causes, such as diabetes mellitus, then there can be vasculitis, HIV, infections, and leprosy. Coming to the physiology, mononeuritis, as said, it's a form of peripheral neuropathy. So localization of the nerve damage begins at the level of nerve root, which leads to loss of function of the particular nerve involved. This involvement may occur at various sites, such as the neuromuscular junction, which can result in loss of sensory or motor deficits or both. Neuropathy involves disturbance at the root level. It can cause root pain or symptoms of myotomal distribution or of dermatomal distribution. The pathological sequence of nerve damage starts, as said, from the nerve root. It can progress to demyelination and eventually to axonal injury. When we come to diabetic patients or the diabetic causative factor of mononeuritis, ischemic injury of the particular individual nerve is commonly observed, which progressively leads to nerve deficits. Coming to the prevalence and types, so mononeuritis in general population we can only find in 0.01% to 0.1%, and when we focus on diabetics, in diabetics we can find in 0.5 to 1% of the population. So as said, mononeuritis is a form of peripheral neuropathy. So touching upon the topic of peripheral neuropathy.
You are presenting any case or you just telling us about the mononeuritis multiplex?
Sir, mononeuritis multiplex based on case. The case.
Where is the case? So you start with the case.
So in our OPD at Lord Patna Medical College, we have come across a patient who had been visiting since past 3 years with chief complaint of feeling of numbness of bilateral lower limbs, mainly the right limb, cramps, burning sensation of feet and lower limb, especially on cold exposure. And patient also had complaint of weakness in lifting up lateral toes, mainly felt on walking. She has been a known case of type 2 diabetes mellitus since 2 years and has been on treatment since then when she was diagnosed. Prior to that, she has never had any regular checkups. And once she was diagnosed, she was on anti-diabetic medication, calcium and vitamin D. On examination of the patient, on general inspection, asymmetry was observed in the right calf muscle bulk. And on examination, sensations in bilateral upper limb were intact. Right ankle and calf sensations were reduced. Proprioception was preserved. Increased sensitivity to cold temperature was observed in the right ankle and calf. On anthropometry measurements of the right lower limb, on measuring the circumference, right calf was 18 cm and left 21 cm. So we observed a difference of 3 cm. On inspection and on examination of the motor system, the right limb the right ankle dorsiflexion 4/5 and toe extension was found to be 3/5. Left limb, we didn't find any deficits, nor in the upper limb. The laboratory trends, what we found since the beginning that we had measured, we took HbA1c levels, postprandial blood sugar levels and the TSH levels we monitored. Since by tracing the reports starting from the year 2022 to 2025 currently, the HbA1c level started at 11.2%, and then after since the time she was diagnosed, she was started on anti-diabetic medications and anti-inflammatory agents. So now, at present, into 2025, the current HbA1c level is 5.5%, TSH being 2 and postprandial blood sugar being 210. We also did nerve conduction studies, mainly both upper limb and lower limb. And when we did the nerve conduction studies of the lower limb, what we found in the amplitude and nerve conduction velocity, the nerve conduction velocity of right lower limb was reduced, signifying especially the peroneal nerve. Also, there was mild reduction in the nerve conduction velocity in right tibial nerve, but significant was right peroneal nerve, and no such abnormality was found in the left limb. So now I can go to the
What treatment we have given?
First, initially we had to manage the glycemic control since she has been a chronic known case of type 2 diabetes mellitus. So we had started with OHAs, mainly sitagliptins. Initially we had started metformin, but metformin also since it causes vitamin B12 deficiency, and since we found a case of mononeuritis in her, we later stopped metformin. Since B12 deficiency also leads to peripheral neuropathy. Then for pain management, through the years, since past 3 years, it has reduced, but it has not completely stopped. She still faces the symptoms. We started on gabapentin and pregabalin NT, and lidoderm patches provided and supported for anti-inflammatory drugs and vitamin D and calcium.
Any conclusion you have? So just
Actually, first this was one case, ना? Case series नहीं है, एक case है.
This is one case.
Okay. तो इसमें exactly वो उस समय से उस एक case को follow कर रहे थे हम लोग.
हाँ, मैम when she came right
तो
now.
उसके पेन को जो रिडक्शन हुआ उसके लिए कुछ स्केल यूज किया गया था क्या? जैसे वो तो तुमने किया HbA1c रिडक्शन हो रहा है, वो रिडक्शन हो रहा है, बट पेन रिड्यूस हुआ. जैसे यू आर टेलिंग कि पेन रिड्यूस हुआ, बट डिड यू यूज अ स्केल? क्योंकि यू आर फॉलोइंग दैट पेशेंट ऑल्सो डॉक्यूमेंटिंग इट.
Ma'am, we mainly I am concluding because the pain has reduced only by the basis of patient's verbal answer.
तो what are the pain scales जो हम यूज करते हैं मतलब पेशेंट के लिए ये के लिए? किसी को अगर पेन हो रहा है तो व्हाट इज द मतलब क्वालिटेटिव जो ये यूज करते हैं टेस्ट पेन मतलब जो हम यूज करते हैं पेशेंट के लिए कि पेन अभी का क्या पेन है एंड देन फॉलो अप में विजुअल एनालॉग स्केल ये सब यूज करते हैं. बताएगा या स्माइल?
Yeah, the smile scale.
Smile is good, very good.
1 to 10.
So Aditya, it is definitely a good thing that you have presented in your first year. Like it is the first part that is very impressive. But I think, is there anything, how we check the sensory system in the, look for peripheral neuropathy in diabetic patient in nobody? How we check for peripheral neuropathy? How we screen it? With which instrument we screen it?
Like we check it for both sensations and motor.
Sensation, how we check sensations?
Like by taking cotton wool and.
Cotton? Now you are postgraduate.
And pinpoint.
Cotton से बड़ा चीज़ लेना पड़ेगा तुम्हें कुछ. क्या लेते हैं?
वो hammer.
Hammer. Anyone pass out?
This.
10 gram monofilament test, है ना? It is called monofilament. So yes, it is very good. You have presented very well. Thank you.
Thank you.
Thank you, Doctor. Now we have call upon stage Dr. Ankit from IGIMS.
Good morning, sir. Good morning. Good afternoon, everyone. I am Dr. Ankit Kumar, first year resident in emergency medicine from IGM's Patna. I am here to present a atypical case of patient with diabetes mellitus. Case was a 52-year-old male presented in emergency department with 2-day history of progressive nausea, fatigue, vague abdominal pain, shortness of breath, poor oral intake, associated with the comorbidities, type 2 diabetes mellitus for 12 years and on medication of empagliflozin 25 mg daily and metformin 100 mg overall, and has a history of ischemic heart disease 3 years back. On physical examination, he was mildly dehydrated, tachypneic with deep respiration, soft abdomen with no water. On initial emergency evaluation, BP was 110/70, pulse rate was 112 beats per minute, respiratory rate was 24 per minute, saturation was 96% on room air, and GCS was E3, V4, M5. Temperature afebrile and random blood glucose of 168 mg per deciliter. I was working with the provisional working diagnosis of diabetic ketoacidosis, acute coronary syndrome, acute gastroenteritis, and sepsis. With related provisional working diagnosis, I have been get the investigations done with a pH of 7.18, serum ketones of 4.2, anion gap of 24, bicarbonate of 12, urinary ketones +3, glucosuria was present, CHOP-T was negative, ECG of sinus bradycardia, and on focus everything was normal. So next is diagnostic approach in ED was initial lab, blood gas was done,
Access the pH and bicarbonate level. Electrolytes was anion caps calculated mentioned earlier, and the serum ketones, especially beta hydroxybutyrate, blue gold standard, with a level more than 3 millimoles per liter, supports the diagnosis. And my final working diagnosis of euglycemic diabetic ketoacidosis. What is euglycemic diabetic ketoacidosis?
You go with the treatment. What treatment you have given? Just skip it.
Sorry, sir?
Treatment you have given. Just skip this.
Skip this?
Yes. You, what punishment you have given? You just tell this.
Sir, we have given the management part. I am going through the what is a euglycemic diabetic. Okay, sir. The management algorithm for euglycemic diabetic ketoacidosis is same as that of the diabetic ketoacidosis, with the crucial enhancers like main culprits in the euglycemic diabetic ketoacidosis is patient is already on the SGLT2 inhibitors. The SGLT2 inhibitor role is to enhance the glucosuria, and because of that, the serum blood glucose appear normal, but all the features of diabetic ketoacidosis persist apart from the hyperglycemia. So, main culprit drug, SGLT2 inhibitor, should be stopped immediately. IV fluids, isotonic line for volume resuscitation, IV insulin infusion fixed rate of 0.05 to 0.1 international unit per kg per hour. Goal is to close the anion gap, not however to reduce the blood glucose. Dextrose infusion is a critical step. Start the D-gain early. Hypoglycemia while continuing the insulin to clear the ketones. Monitoring serial BBG monitoring, electrolyte, anion gap, and ketone every 2 to 4 hours. Transition to the subcutaneous insulin. Start a basal insulin for 2 to 4 hours before stopping the insulin drug. Dose based on the weight. 0.3 international unit per kg per day for at least 6 to 8 hours IV insulin requirement. Don't stop the insulin drip prematurely. The risk of relapse is high. Discharge planning, patient education is vital. Discuss the sick day as discussed earlier in the panel discussions. Ketone monitoring, cautious reinitiation of the SGLT2 inhibitor only after discussion with the endocrinologist. Here is a documented case discussion with the BMJ Journal of Euglycemic Diabetic Ketoacidosis published in July 2023 with the conclusion that euglycemic diabetic ketoacidosis is a life-threatening and a challenging diagnostic dilemma that is becoming more widespread with the growing use of SGLT2 inhibitor drug. This review highlights the need of the great awareness for EDK among the medical community. We share among the approach of diagnosing and treating the EDK to help the guide clinician. Patient education is particularly important and should be discussed prior to initiation of the SGLT2 inhibitor. Healthcare personnel must remain vigilant and educate the patient on the risk and warning signs of EDK to reduce the instances of misdiagnosis and improve the overall patient outcome. The take-home message from this is EDK is emerging and a dangerous complication linked to SGLT2 inhibitor. It is a diagnostic trap in the ED due to the lack of the significant hyperglycemia. Management requires vigilance, early ketone testing, concurrent dextrose with insulin, and a prolonged careful transition to the subcutaneous therapy to prevent the relapse. Awareness and education for both healthcare provider and the patient are the key to prevention and a timely treatment. References from the for the same is here. Thank you, sir.
Okay. Tell me other causes of euglycemic diabetic ketoacidosis other than SGLT2.
There are the multiple causes can be the euglycemic diabetic ketoacidosis. My case study was related to the SGLT2 inhibitor, but other cases can be patient has taken the ultra short acting insulin right now, but has checked the insulin level, but taking the ultra short acting insulin right now, but have not resolved the ketoacidosis part. So that will lead to the diabetic ketoacidosis of euglycemic type.
Other than that, you should rule out all other causes. And one last question, tell me what are the reasons behind the pain abdomen in diabetic ketoacidosis?
Sir, pain abdomen of the diabetic ketoacidosis can be associated with the ketoacidosis part of the patient leads to the pain abdomen. Ketone body accumulation, lactate level accumulation in the body can lead to the increased amylase lipase and resulting in a progressive pain in the patient. How invalid is it?
Progressive inflammations of the tissues near the pancreas will lead to the pain which...
No, pancreas is normal. It's okay.
Can you tell me some other side effects of SGLT2 inhibitors apart from UTI?
So UTI is the most common side effect of the SGLT2 inhibitor because SGLT2 inhibitor causes a glucosuria, which if the patient is not doing the proper hygiene of the routine urinary hygienes, or especially the female patient, that will lead to the more severe UTI, which can progress to the cancers of the urinary bladder also in the females.
How do you differentiate starvation ketoacidosis and euglycemic decay?
Sir, for the starvation ketoacidosis, patient will tell me the history of starvation. Basic when we take the history from the attendant or patient, will have the history of starvation that the patient was on prolonged fasting, that is of 8 hours or more than 36 hours, he was starving. That is on the basic differences. Second is basic history में clear हो जाएगा कि patient was starving, और फिर beta hydroxybutyrate level and ACA, acycloacetone levels in the blood can also be elevated in the diabetic ketoacidosis patients.
Can metformin precipitate euglycemic decay?
Sir, risk with metformin is not as such with the many studies that has been done, but with the SGLT2 inhibitor it is very much prominent because like I said, SGLT2 inhibitor act on the PCT of the kidney, so they enhances the glucosuria, so resulting in the body blood glucose level remains low, but other features of diabetic ketoacidosis versus like the acetone levels elevates and ketones body serum and urines are elevated.
What is the common side of metformin? Side effects of metformin? एक बोलना है तो what is the common?
Sir, hypoglycemia. Lactic acidosis.
Most common क्या होता है?
Lactic acidosis.
Sorry sir. अरे अभी ये सबको सबसे ज़्यादा पता होता है वो.
Nausea, vomiting.
बोलो ना.
Yes sir.
अच्छा एक चीज़ बता दो लास्ट, यूरिन में हम कौन सा कीटोन्स चेक करते हैं?
Beta hydroxybutyrate and acycloacetone levels.
अभी दो साल हैं पढ़ने के लिए.
What are the different types of ketone bodies?
Ketones bodies.
Thank you so much. Thank you Ankit. Thank you Ankit. From news.
Faculties and chairperson. Myself, Dr. Kailas More, third year resident from Patna, and today I am presenting the thesis. My thesis. The topic is association of serum prolactin level with glycemic control in type 2 diabetes mellitus, an observational cross-sectional study under the guidance of Dr. Vijay Kumar sir, additional professor, Department of General Medicine from Patna. The introduction. As we know, the diabetes is a major health problem in India. Diabetes mellitus is the group of
methodology. Up to the methodology.
Methodology, study design. Aim of my study to find out the association of serum prolactin with the glycemic control in type 2 diabetes mellitus. Objective to determine the association of serum prolactin level with glycemic control in type 2 diabetes mellitus. Methodology, the study design. It is an observational cross-sectional study. Study participant, all the adult patients which presenting the IPD-UPD in General Medicine AIIMS Patna will be taken for the study.
Accordingly, inclusion and exclusion criteria. Study duration is approximately 18 months. Budget is nil. Inclusion criteria. All the patients more than 18 years of the age coming to the IPD, OPD, General Medicine of the AIIMS Patna, and the diabetes, type 2 diabetes mellitus, which is newly or already diagnosed. Exclusion criteria. Type 1 diabetes mellitus, thyroid disorder, prolactinemia, drug that causing hyperprolactinemia, pregnancy, and the patient who were not giving the consent for the study. Sample size calculation. Sample size calculator by calculator based on the prevalence of diabetes of the Indian population, which is being 12%. Assuming that 12% of subject with the population of type 2 diabetes mellitus, the sample would require 165 with estimated expected proportion of 5% absolute precision and 95% confidence. And the sampling technique is non-probability sampling subtype. The patient were subject to the following investigation, which include SBNC level, fasting plasma glucose level, postprandial plasma glucose level, serum prolactin, and other KFP and USP level. The study procedure: patient presenting to the AIIMS Patna with newly or already diagnosed diabetes mellitus as per the WHO criteria. After that, detailed history and general physical examination as per the program will be done, and the serum prolactin level will be checked, and the glycemic control of the status of the patient were investigated. Based on these findings, patient will enroll into two groups with good glycemic control and poor glycemic control, and from this data will be collected and analyzed with appropriate statistical tools. In which patient with type 2 diabetes mellitus were categorized into two groups. Group 1, which is a patient with good glycemic control, and Group 2, patient with poor glycemic control. And the glycemic control was defined as per WHO. SBNC value is below 7%. Fasting glucose value is less than equal to 126 mg per day, and postprandial is less than 180 mg per day. And for prolactin, which is divided into three groups, with the normal prolactin were given between 4 and 23 nanogram per ml, in which categorized low prolactin level is less than 4, and normal prolactin is in between range 4 to 23, and high prolactin level is more than 23. The statistical analysis, proper data will be collected, and the Microsoft Excel spreadsheet is used. Descriptive and inferential statistical analysis will be performed using the software, Jamli software, and the correlation between these two categorical variables will be evaluated with the chi-square or Fisher-Exact test based on their distribution. For all statistical analysis, the p-value should be less than 0.05 will be regarded as a statistically significant value. The study of this result of the study. The study include 165 participants, in which age range is 28 to 89 is with mean age is 58, positive to 12.38 years, and median age was 59 years, and the largest proportion of the participant is belonging to 50 to 60 years age category, followed by 60 to 7 years, with the male population is higher than the female population. And this is a demographic and baseline clinical characteristics, in which the age in between 41 to 61 is major population, and the male is greater than the female. Male is more than the female population, with SBNC is more than 7. That is, poor control is higher population in the study than the normal good control. And
so what is the difference between the well-controlled and uncontrolled variant? जो आया होगा ना, वेल कंट्रोल्ड और अनकंट्रोल्ड ग्रुप में क्या क्या प्रोलैक्टिन लेवल आया?
प्रोलैक्टिन लेवल।
हाँ वही तो तुम्हारा एम है।
हाँ सर वही this primary outcome in which in a poor glycemic control there is a slightly higher proportion with elevated prolactin level, more than 23. Elevated prolactin level in poor glycemic control is 29, that is 30%, and in good glycemic control it is 27%. So slightly higher with increased prolactin level in poor glycemic control. And majority is included between normal level, 4 to 23 is normal level. So majority participant with good and poor glycemic control is present between normal level. Overall normal prolactin level we are most common category in both glycemic control groups. With statistical analysis by Fisher exact test, there is no significant association between prolactin level and glycemic control status. So,
क्या निष्कर्ष निकला इसका?
significant नहीं है association.
मतलब प्रोलैक्टिन का कुछ करने नहीं है इसके साथ।
हाँ सर।
Why you think कि प्रोलैक्टिन का कुछ कनेक्शन होगा डायबिटीज के साथ?
Sir, already our previous study shown us that prolactin may cause beta cell proliferation.
Beta cell proliferation.
Pancreatic beta cell proliferation, insulin secretion, and insulin और good homeostasis of glucose metabolism. ये already study में हुआ. तो and in low to normal physiological level in prolactin, there is a beneficial effect on diabetes level, good glycemic control. But abnormality elevated prolactin level may cause detrimental or worsen the glycemic control of the diabetes.
तो तुम्हें क्या लगता है इसमें पोअर कंट्रोल वाले लोगों में जो 23 से ज़्यादा थे वो ज़्यादा थे ना, वो चार्ट दिखाओ।
हाँ तो उसमें सर थोड़ा
23 से ज़्यादा 30% लोगों के पोअर ग्लाइसेमिक कंट्रोल में ज़्यादा थे, मोर देन 23। दो क्वेश्चन है इसमें, व्हाई यू टेक द लेस देन 4 एज ए क्राइटेरिया and why you have not taken as a more than 100 as a criteria? Because it is said that when somebody is having for high prolactin level, if it is more than 100, then it is mostly due to the pathological causes, and if it is less than 100, then it can be something due to physiological like drug induced or something else. So what is the advantage of taking less than 4 value?
एडवांटेज तो
कैटेगरिकल
करना था और उसके बेसिस पे तो हमने
So can I say like this that those patients who are having poor glycemic control might be using some drugs which can increase, which will be increasing the prolactin level, and that is why their prolactin level is high. Suppose they are having more gastroparesis, they are using more domperidone, and they are having high prolactin level. Can it be the cause? So you have excluded those medication associated prolactins.
Did the gender had any significant association in your study with glycemic status? Because in male and female, the serum prolactin level may be different. So did the gender had any significant association?
No, sir.
इसमें कुछ इंटरवेंशन भी हो सकता है कि प्रोलैक्टिन का एसोसिएशन, इफ वी हैव एसोसिएशन ऑफ लेवल ऑफ प्रोलैक्टिन विद ग्लाइसेमिक, तो प्रोलैक्टिन को लोअर कर दिया जाए तो
दिस इज अ क्रॉस सेक्शनल स्टडी, तो लॉन्जिट्यूडिनल या कोहॉर्ट स्टडी होगा तो उसमें
तो रिकमेंडेशंस क्या थे इसमें स्टडी में? थीसिस तो तुम लोग का सबमिट हो गया।
हाँ, अदर रिकमेंडेशन थोड़ा लार्ज स्केल पे स्टडी होना चाहिए, कोहॉर्ट स्टडी मतलब स्टडी डिजाइन अलग होना चाहिए, और जो हमने कंपाउंडिंग फैक्टर बहुत सारे तो वो निकाल के कर सकते हैं।
हाँ, तो फिर अल्टीमेटली क्या करना चाहिए? हर सब में प्रोलैक्टिन देखना चाहिए?
नहीं, दिस इज नॉट द मार्कर, क्लिनिकल मार्कर फॉर सीवियरिटी। हाँ, नॉट सिग्निफिकेंट, तो प्रोलैक्टिन इज नॉट सीवियरिटी मार्कर फॉर क्लिनिकल।
ओके।
Status of prolactin as well.
So this was in your exclusion criteria.
Why you excluded? I want to say why you excluded? Any status on that?
prolactin type 1 diabetes अलग कैटेगरी और hyperglycemia,
type 2 diabetes is another topic.
Basically, it is also involved beta cells. That is also part of the type 1 diabetic pathophysiology. Why you have excluded? Any reason behind that? Yeah, any status suggesting
type 1 beta cell is type 1 absolute deficiency beta cell, and type 2 में तो related deficiency proper deficiency type 1 इसलिए prolactin का कुछ
is a limitation of this study. What are the different limitations of this study? Limitations.
It is a single center, only single center, or cross-sectional study, or many confounding factors in single center. Sample size.
What is the formula of sample size calculation? Very common question.
ठीक है. Thank you, Dr. Panache.
Everyone, good afternoon faculty, good afternoon everyone who are present here. Myself Dr. Gulshan Biljare and I am resident of emergency medicine in RSSDI Patna. Today I am going to present a case which came in RSSDI Patna. This is a typical case of diabetes ketoacidosis which got complicated by the cerebral edema. This is the case overview. A patient, a previously healthy 12-year-old developed progressive polyuria, polydipsia and weight loss over 3 weeks. From last 3 days began vomiting and non-bilious vomiting. It is a type of non-bilious vomiting, becoming lethargic and had decreased oral intake from last 1 year. Parents noted that the patient is having rapidly breathing and confusion, no fever, no trauma and no association with or contact with the sick patient. Past medical history, no prior diagnosis of diabetes from the family, and the family do not have any history of type 1 diabetes. But his paternal uncle is having type 1 diabetes mellitus. Initial assessment vitals were heart rate was 145 per minute, respiratory rate was 32 per minute, BP was 95/60 mmHg, SpO2 was 97 and temperature was 37.2 at room temperature. Systemic examination, CNS was made and GCS was around 12, that is E3, V4 and 5, lethargic patient and confused but arousal. CVS, that is SN2 was present and respiratory system, bilateral air entry was normal. Per abdominal examination showing soft but tender. Tenderness was present at the time of assessment. Physical examination, dry mucous membrane, over skin turbid, small respiration and footy breath was present. No focal neurological deficit, pupil equal and red eye. Immediate investigation was ordered in the emergency department. Blood glucose was 520 mg per dl, that is hyperglycemia was present. Venous blood group, that is acidotic side, severe metabolic acidosis with respiratory compensation. Basic metabolic panel, which was showing here that sodium was 132, that is hyponatremia, and elevated 1 suggested of dehydration. Severe ketoacidosis, here we can see that the large ketone molecule was present more than 3+ in test, and beta hydroxybutyrate confirmed the diagnosis of DKA, that is which come around 6.8 millimole per liter. Emergency diagnosis was made that severe diabetic ketoacidosis with altered mental sensitivity, that patient came with confusion. Right? Immediate management in emergency department was given. IV access leading to 2-hour IV board cannula was placed and fluid resuscitation was started. 10 ml per kg of body weight with resuscitation fluid of NaCl, that is 0.9% of bolus was given over 30 minutes, and subsequent correction was given for dehydration over 48 hours. Maintenance fluids were also advised. Insulin therapy started continuous with IV insulin infusion and the rate of 0.1 unit per kg per hour. After initial fluid bolus, we have given this insulin therapy. Neurological monitoring has been done because patient came with confusion. Later on, later on, this is I have divided this my whole case into different time perspective. For example, here we have in one starting hours we have given this type of treatment. GCS was stable at 12. GCS was 12 and remains lethargic but responsive. Lab parameter was given here like glucose, which comes down up to 320 mg per dl. pH 7.13 and sodium was 130 and serum osmolarity of 305 milliosmol per kg. Now management, again this management is continued for rest. After 6 hours we have seen that the patient has neurological deterioration. For example, in GCS drop to 9, for example, E2, V2 and M1 was present at that time. Patient become irritable and inconsolable, develop new onset of vomiting and headache. Bedside ONSD was given and we have taken that right side showing 5.3 and left side was showing 5.4 milli and assessment using this criteria. This criteria is Miller Moore Act. This criteria was given by Moore Act. According to him, the cerebral injury can be defined with the help of this major and minor criteria. This major criteria conclude at least have 4 criteria along 4 criteria of major criteria and minor criteria is also having 4 parameters. Out of that, any one major criteria has to be present to call it as cerebral edema or cerebral injury. And minor criteria must have at least 2 symptoms. Here we can see that the major criteria is having that deterioration of mental status is first major criteria and minor criteria we are having vomiting and headache. So these 2 already match the criteria for the cerebral edema. Later on, from 6 to 7 emergency intervention, 6 to 7 hours of emergency intervention, we have achieved that we have started mannitol because we have started mannitol administration over 10 minutes. No images is required to start the treatment, and we have informed the intensivist for the possible intubation, and if required, we have shifted the patient to the ICU. Monitoring has been done. CNS examination has to be done in 15 minutes. Continue cardiorespiratory monitoring was done. According to the time value, according to the time factor, I have adjusted the whole study for our case which present at the emergency department. We have seen that the first hour we have given the initial treatment of fluid. After that, after 7 to 12 hours, we have managed the case. We are watching the case and we have seen that the GCS is continuously improving. And after 12 hours, we can see that the glucose level came around 180 and pH value is going upside, that is 7.2, and sodium is also going up, that 134. And here we have ordered the MRI brain for the same patient, and we have seen that here we can see that consistent mild diffuse cerebral edema was present at the time of after 12 hours. And on day 2nd, GCS was completely fine. That is, GCS came around 15, and metabolic improvement we can also see. So, for example, here pH directly came to 7.35, and bicarbonate is up to 18. Now the patient has been transferred to the normal ward, and glucose has been monitored. And on 5th day, everything was corrected. Metabolically, patient was stable. On 6th day, our final diagnosis was new onset diabetes mellitus, diabetic ketoacidosis with cerebral edema, and resolving metabolic acidosis. This is my final diagnosis. And after that, we can see that diabetic ketoacidosis will cause cerebral edema. Here are some studies which shows that cerebral edema is causing major significant changes in outcome. As we have seen that our sir, Dr. Anand sir has already been told that if a patient came with a diabetic or ketoacidosis with cerebral edema, the outcome will worsen. For example, 30% mortality is present in such patients. Clinical significant, that is often 0.3 to 0.9% of pediatric decay episode is present, sir. Imaging is not required that much. So these are the physiology for developing adhesive diabetes.
You didn't mention any clinical signs of raised ICP in your case.
Sir, I have shown in the form of GCS, sir. GCS
clinical signs. What are the clinical signs for raised intravenous bedside?
Sir, in bedside, sir, I have given directly OSD I have done.
Clinical signs.
Clinically, sir, patient.
Clinical signs of raised ICP.
Patients, sir, will complain of headache and.
Signs. I'm asking for the signs, the symptoms.
Yes, sir. Pulse.
Which year resident?
First year.
First year. 6 months yet?
8 months.
8 months. What are the signs of raised ICP? किसी मात्रा प्रेशर बढ़ रहा है कि क्या हो रहा है? कुछ होता है?
Sir, heart rate will decrease. Heart rate will decrease, sir, and
वो मीटिंग में कुछ स्पेशल होगा डेली कैप्चर
eye changes, also localizing signs.
Yes, sir. In fundus we can see that papilloedema process, and in emergency department we check for, in ONSD we check for diameter for sheath.
Also localizing signs. Also localizing signs. You are very fascinated about ultrasound in emergency. So now you tell me what is the how you use ultrasound for. Have you done transcranial ultrasound for this to look for cerebral injury?
Sir, for cerebral changes we have not done, sir. For ONSD.
होता है देखते हैं.
Sir, I have never seen, sir. But for ONSD we have done for so many patients.
LP क्यों नहीं किया इस पेशेंट का?
LP, sir, अभी तो
हमने भी डिस्कस किया ना कि डीके का प्रेसिपिटेटिंग कॉज देखना है.
राइट सर.
इन्फेक्शन हो सकता है.
यस.
अल्ट्रेशन सोडियम में है बच्चा, तो एलपी क्यों नहीं किया?
सर, एक तो सबसे पहली बात सर उसको फीवर नहीं था.
फिर कहती हैं टाइप 1 डायबिटिक है.
हाँ सर.
नहीं होगा.
सर और ओएनएसजी में सर अभी हम लोग अगर रेज आईसीपी मिल जाए तो हम लोग को रिपोर्ट करना होगा एलपी से. फंडस एग्जामिनेशन करके देखना होगा कि अगर ज़्यादा इंट्राक्रेनियल प्रेशर रेज होगा तो हर्निएशन के चांसेस हो सकते हैं.
इसलिए नहीं किया.
जी सर, पहले ट्रीटमेंट स्टार्ट किया उसके बाद कुछ.
While treating a case of decay, what precautionary measures will you take to minimize the chances of cerebral edema during treatment?
First of all, sir, we have to choose proper IV fluids. That is, we have already explained that the normal saline is the treatment of choice. That is the main line of treatment, sir. If we lose our this therapy, for example, if you take fluid, if we do not correct the fluid in time, or we have not corrected proper, if we have not given proper the fluid resuscitation, that can lead to the edema, sir. Secondly, sir, if we correct rapidly, also in that condition, also the vessels get damaged and can cause edema further.
What about sugar control? Very rapid reduction in blood sugar will also cause cerebral edema, and even hypocardia can cause.
Yes, sir. And there is a concept called, sir, reperfusion. Again, for example, if patient we have corrected rapidly, for example, we have corrected rapidly IV fluid as well as insulin we have corrected rapidly, that may again lead to further damage.
Apart from mannitol, another drug to be used?
3% NSAID has to be used.
Hypertonic.
पेशेंट इरिटेबल है, पेशेंट ऑल्टर्ड सेंसोरियम में अगर जा रहे हैं, एंड यू हैव टू अगर योर अदर डिफरेंशियल्स क्या क्या होंगे. एक तो सर्कुलर एडिमा तुमने बोला, एंड तुम बोल रहे हो रेज आईसीपी है कि तो विल नॉट विद होल्ड एलपी. अगर एलपी करना होगा तो कैसे करना?
अगर
इंकेफ्लाइटिस इज आल्सो या अदर डिफरेंशियल्स है तो मदद करो.
Yes, ma'am. We will check for neck rigidity, ma'am, or we will check for fever. If fever or temperature is raised, we will go for LP. And if
फीवर नहीं है, neck rigid लग रहा है तो
neck rigid लग रहा है तो ma'am we will go for further sign for turning and Brzezinski sign. We will check once again. And if we will find positive, then we will again go for LP, ma'am.
और अगर एलपी तब भी तुम करने का डिसीजन ले तो इन स्पाइट ऑफ कोई बाकी फाइंडिंग है तो कैसे करेंगे?
मैम फिर फॉर एग्जांपल मैम इसमें सेरिब्रल एडिमा में मैम ये भी हो सकता है कि उनको वीकनेस डेवलप हो, हाथ में वीकनेस हो सकता है, फोन लिंक में कभी वीकनेस डेवलप हो सकता है। तो हमको ऐसा लग सकता है मैम ये हो सकता है कि कोई जीबीएस का न्यू फीचर अराइज हो रहा हो, उसके लिए भी हम लोग एलपी कर सकते हैं इस कंडीशन में।
तो कैसे करेंगे? रेज आईसीपी है ना, तो इसको यू आर सस्पेक्टिंग कि वो हो जाएगा, हर्निएशन हो जाएगा, तो कैसे करेंगे?
मैम फर्स्ट ऑफ ऑल उसको रेज आईसीपी रिड्यूस करने की कोशिश करेंगे मैम। फर्स्ट ऑफ ऑल सर मैनेटॉल एंड 3% NaCl has to be advised. We will check for further deterioration or improvement of the disease. जी सर।
दवाई कम कर सकते हैं। एमरजेंसी फिजिशियन को सब कुछ पता होना चाहिए। ठीक है जी, थैंक यू डॉक्टर गुलशन।
थैंक यू।
अच्छा तो हम लोग बहुत हो गए, हम दे देते हैं। चलिए आइए डॉक्टर शर्मा। मोमेंटो डॉक्टर गोविंद को भी नहीं मिला है भैया।
हाँ गोविंद आइए,
ऐसे नहीं बच्चे बार मिले। So all of you have presented well, but just my take home message बस यही रहेगा कि मेरे ख्याल से जब प्रेजेंटेशन करने आए आप नेशनल स्टेट लेवल पर भी, तो आपने जो गाइड की या अपने एचओडी के जान खाकर आए कि हम क्या प्रेजेंट करने जा रहे हैं, ऐसे प्रेजेंट करने जा रहे हैं, और उनसे इनपुट ज़रूर लें, है ना, उनसे इनपुट ज़रूर लें कि और एक आध बार प्रैक्टिस कर लें तो और अच्छा रहेगा। अपने डिपार्टमेंट में एक आध बार प्रैक्टिस कर लें तो सबसे अच्छा रहेगा। अपने आप फायरिंग करके आओगे ना तो अच्छा करेंगे।
युवा टैलेंट रिसर्च अवार्ड
गोविंद पांडे नहीं देखा तो कैसे मानते हैं? तो चारों बच्चों को ही बुला लो जो अपने प्रेजेंट किया, उनसे बुला लें। चारों प्रेजेंट करते वो आ जाओ। पिछले वाले उसने भी मैंने उसको दिया। आ जाओ प्रेजेंटर्स, आ जाओ।
अरे प्रेजेंटर जो भी आ जाओ सब।
और जो नॉन प्रेजेंट करते हैं वो लोग फोटो खींचे बैठो।
अगला बार तैयारी करेगा।
हाँ, ये सब लोग रिलैक्स मूड में है। मुझे पुराने वाले कह रहे हैं दोबारा। हाँ वही है, नए लोग के साथ चलो आ जाओ
प्रेजेंट किया आ जाओ।
कोऑर्डिनेटर थोड़ा अच्छा काम करेगा।
पहले फोटो टेक लिया है, टेक लिया था, एक ही लोग। चलो आ जाओ,
उधर पे बुला लीजिए, उधर पे खड़ा।
चलो आ जाओ,
आइए ज्योति जी आइए।
डॉक्टर नयन आ जाओ।
कहाँ गए सब?
छोटा कुनबा है, आ जाओ। डॉक्टर नरेंद्र क्या इतना क्यों सम्मान हो गया?
तुम लोग भी आ जाओ सब।
डॉक्टर जन्मेश्वर
सब आ जाइए।
डॉक्टर अशोक आ जाओ। मैट्रोमोनियल के नहीं जा रही तुम्हारी फोटो। आ जाओ आदि
भेज भी चले तो नहीं इसीलिए नहीं सकता।
आ जाओ दिवाकर आ जाओ। तुम्हें स्पेशल वाले डोली भेजनी पड़ेगी यहाँ से।
ये उधर मिलेगा फोटो में नहीं मिलेगा अपना
अच्छा वो चेहरा
देखो हमारा आ गया नहीं मारा अरे वही तो फर्क है कॉफी 1 घंटे से मंगवाए
वो सब बाहर में दिया अच्छी से फोटो खींच के दिया
मिल जाएगा ना फोटो कैसे मिलेगा
चेहरा देखिए मिल जाएगा लेंगे चेहरा देखिए और फोटो लीजिए गोविंद जी लिए हैं भाई गोविंद जी का बड़ा कैमरा है
क्या हो गया सर इसमें तो बताओ के लोग को रसगुल्ला चल रहा है अरे उसमें तो मैं सच कहूं तो
आपको जाना है क्या लेना है ये बताइए लेना
Please sir, kindly come on the front. Both of you, आप दोनों भी हैं. So okay, anyone else? They are coming. We were expecting quite few more residents.
Because the timing is 5:30. So we have to wait for 10 to 15 minutes more.
Initially we planned to go with 2 rounds. Today was the screening round, and then we wanted to do the main quiz round tomorrow. But if only few of them are there, then we'll have to wrap it today only. So let's see how many of you turn up today. Anyone who is on the way or reaching? To announce the winner after 1 round only because of only few participation. आप अकेले हो आपके साथ कैलाश team up with Dr. Divakar. Where is Kailash?
नेगेटिव मार्किंग भी है याद रखना है 1 मार्क नेगेटिव है
देखिए आपका स्टूडेंट
हो गया नाम मत दिए मोबाइल नंबर डिपार्टमेंट
Third winner is Satyam Kumar, IGMS, and Rishabh Kumar. ठीक है, 50 मार्क्स. एंड सेकेंड पे दो पोजीशन, दो लोग हैं. फर्स्ट है डॉक्टर दिवाकर एंड डॉक्टर मलाला. कैलाश, डॉक्टर दिवाकर एंड कैलाश, सॉरी. एंड सेकेंड है मोहम्मद आदिल एंड नेहा राज. सेकेंड पोजीशन में दो पर्सन है विद 57 मार्क्स, टाई अप हो गया. एंड थर्ड पे कुमार, गुरुराज एंड आशीष प्रधान, 70 मार्क्स. नहीं है क्या वो? इनको सारे को विनर्स को प्राइज दिया ना.
स्टैंड एट योर पोजीशन है ना. डॉक्टर गुरुराज एंड डॉक्टर आशीष प्रधान.
But
you are the winner. First winner. Second, Dr. Divakar and Dr. Kailash.
Divakar and Kailash.
Stand up. And Dr. Kailash, Dr. Divakar.
ठीक है. सेकंड पोजीशन में दो पर्सन है, एक और टीम है.
एक और टीम है डॉक्टर मोहम्मद आदिल एंड डॉक्टर नेहा राज.
ठीक है.
ओके.
एंड थर्ड पोजीशन पे
डॉक्टर ऋषभ एंड डॉक्टर सत्यम.
कल वैलिडेटरी फंक्शन है 2:30 to 3:30 को, उसी में प्राइज मिलेगा. ठीक है. प्राइज और सर्टिफिकेट कल उसी समय रहेगा. क्या? नहीं, हम फाइनल हो गया. और कल पोस्टर प्रेजेंटेशन का भी प्राइज, सारे का सर्टिफिकेट एंड प्राइज उसी समय मिलेगा. ठीक है. ओरल का भी है.
More important.
देना है क्या?
यही नहीं, ये टेबल सामने ऐसे लगा दीजिए. ये टेबल इधर. हाँ, यही दे देंगे. ठीक है. मोबाइल से फोटो खींचो, खाली खड़े रहो.
हाँ सर.
लोग आ जाओ, तुम लोग आ जाओ.
अच्छा, बाकी लोग कुछ लोग चले गए, जो लोग हैं उन्होंने सर.
ये लो.
Respected office bearers of RSSDI BIHAR and respected members, now after exhaustive scientific deliberations, we would like to start our general body meeting. So for that, I would like to invite first our chapter chairman, Dr. Subhyo Mukherjee sir, to kindly take your seat. And chapter treasurer Dr. Manish Kumar Prasad to kindly have your seat. So I welcome you all for this general body meeting. First of all, yes. मोदी सर आ गए. मोदी सर नहीं आए सर, नहीं आए. मोदी सर को फोन करिए, एक्सिक्यूटिव कमेटी मेंबर भी हैं मोदी सर. खबर कर दीजिए, ऊपर है मोदी सर.
So there is no apology as such because all the executive committee members and all the office bearers are present.
Can I sit here?
Sure, sir.
Fine.
So before we proceed further, we have one condolences. Our very senior member, retired professor from Patna Medical College, Dr. P.K. Verma, had passed a few months back. So, in his memory, we would like to have 2 minutes silence, standing silence for 2 minutes. Thank you. Now next agenda is adoption of chapter chairman elect. Since the conference is somewhat earlier, so the election of chairman elect is yet to be declared. Rather, it has been declared from January 1st. So we will have our chairman elect by 15th of February. So we are deferring from this agenda. We are going to next agenda. Next agenda is chapter treasurer's report. So may I invite our chapter treasurer, Dr. Manish Prasad, to just submit his report. Dr. Manish.
ये सर बैठिए ये शरीफ है चला
थैंक यू सेक्रेटरी सर। पिछले साल 2024-25 के ऑडिट रिपोर्ट के बाद 1 अप्रैल 2025 को हम लोग 2 अकाउंट हैंडल करते हैं। एक जो बेसिक अकाउंट है जो बहुत पहले से चला आ रहा है और एक करेंट अकाउंट है जो कि 6th एनुअल कॉन्फ्रेंस दरभंगा को में ओपन किया गया था। उस अकाउंट को हम लोग कॉन्फ्रेंस से रिलेटेड जो भी काम है वो करेंगे, फिर जो पैसा बचता है उसको हम लोग सेविंग अकाउंट में डालते हैं। तो 1 अप्रैल 2025 को हमारे पास करेंट अकाउंट में 10,29,619 रुपए थे। 10,29,619 रुपए, जो अभी 16/11 को, चूँकि अभी कॉन्फ्रेंस हम लोग का 8 अभी ऑन गोइंग है, अभी इस पर बहुत पैसे आने हैं और बहुत डिपॉजिट्स होना है और खर्चा भी होना है। तो प्रेजेंटली 16/11/2025 को हमारे पास इस करेंट अकाउंट में RSSDI के 9,23,395 रुपये है अभी तक। हमारे सेविंग अकाउंट में जो कि 1 अप्रैल 2025 को 8,05,000 रुपये थे सेविंग अकाउंट में, जो 16/12 को हमारे पास 6,30,759 रुपये रह गए हैं। अब तो इस सेविंग अकाउंट में हमारे पास अभी 6,30,759 रुपये है। हमारे पास 2 फिक्स अकाउंट्स हैं तो कलेक्टिवली मिला के एक है 32,53,871 रुपये का, और एक अभी हम लोगों ने जो फंड से पैसा आया औरंगाबाद से और दरभंगा से 2 थोड़ा बचा, उसको हम लोग 27/10/2025 को 20 लाख का फिक्स कर रहे हैं। तो कलेक्टिवली अभी हमारे पास टोटल 52,53,871 रुपये अभी तक हमारे पास। थैंक यू।
Thank you, Dr. Manish. Now next agenda is secretary report. So the new team has resumed its charge from 1st of April 2025, and the colleges were there during the annual conference at Aurangabad. After that, under the guidance of our chapter chairman, our mission and our vision was there: delivery, advocacy, research and equity. Based on that, we have planned our programs throughout the year, and we have started our first CME at Hotel Moria in April only. We have some glimpse. Then after that, we have done one CME in collaboration with Department of Medicine, Government Medical College Betia at Betia, and our executive committee members were also there. The conference was attended by all the UG students and residents of Government Medical College Betia. Then after that, these are the media coverages of Betia Medical College. Then after that, there was a community outreach program, national community outreach program at Lucknow. It was inaugurated by our national president-elect Dr. Anuj Maheshwari. So in continuation to that, we have also planned community outreach program, and we have launched, rather Bihar was the second state after UP to launch and inculcate the community outreach concept. And we have one diabetes update and community outreach program at Darbhanga Medical College. That was also attended by so many of us, and including the national president-elect Dr. Anuj Maheshwari. So these are some glimpses of the diabetes update and community outreach program at Darbhanga Medical College. Then after that, there were district coordinators. We have assigned 18 or 19 district coordinators from different districts, and for them we have a district coordinators orientation program. Again at Hotel Moria we have organized a district coordinators orientation program that was attended by most of the district coordinators and executive committee members. Then after that, we have planned, actually at that time we planned for physical CME, but due to some reason or other, we were not able to organize or to attend some physical CME. Then we have started virtual CME, monthly virtual CME since August, and we are organizing these monthly virtual CME at every month, and these CMEs are being witnessed by our members also. In large numbers they are participating in each and every CME, and one by one, day by day or month by month, we are increasing the numbers also as far as the participants are concerned. Then in the meantime, in last conference, we have a very vast participation, or the participation of our members at National Conference at Kochi. By our advocacy, we have managed to get almost 20 chairpersons slot and almost 15 speaker slot we could arrange for our members. Whoever are interested, we have approached to each and every member, and whoever are interested for chairpersonship or for speakership, we have tried to accommodate them, and they were assigned chairperson or speakers opportunity there during the national conference. Then at that time there was a great news for us also, that we have planned the research retreat, which is a research program of RSSDI. There are usually two conferences, one is national conference, another is national research retreat. So research retreat, they are usually being organized at some other centers, like previously it was organized at Madurai. Then this year, 2026, the research retreat is being organized at Guwahati. So we have applied for research retreat, and by all the members, by the effort of all the members, and especially our zonal member elect and our chairman, chapter chairman, we could manage to get the research retreat 2027 at Bodh Gaya. Then, in the meantime, before national conference, there was an election of RSSDI, and before that, there was no participation from RSSDI BIHAR in national RSSDI. But again, due to our advocacy and equity, we could manage to get a seat there, and you will be happy to congratulate Dr. B.K. Singh sir, who has been elected as zonal member, RSSDI zonal member. He has been elected, and he is going to take charge from 1st of January. 1st of January. In the meantime, there are certain achievements which, though I have highlighted, but membership. Earlier, I think in last 1 year, we could manage to add around 180 members in last 9 months, 180 members, live members. And you will be surprised to know that in last 10 days, we have managed to add 13 live members. Based on that, we have offered that we will be giving you complimentary registration, please be our member. So, by that formula, we have managed to get 20 to 22 members in last 1 week. चेयर और आगे कर दीजिए ना, एक दो चेयर आगे कर। So in last 7 days we could manage to add 22 members. Then community outreach, because that is the dream project of the current president, Dr. Anuj Maheshwari. So in alignment of that, we have started our community outreach, and certainly we are going to plan another community outreach in near future at Sitamarhi, being led by Dr. S. Jasar in February. So that's Jasar will elaborate. Then CME in remote areas, we have tried to manage. Betia was in that series. Then we will try to continue CME in remote areas so that we can reach to periphery, or we can reach to the primary care physicians. Then we have almost participated in all the different campaigns of RSSDI, and recently hypertension challenge was there, and you will be happy to know that Bihar stood first in the hypertension challenge by beating all the pioneer states like Tamil Nadu and Andhra. They were doing earlier, they were doing better, but last year we could manage, or we have rather participated, and we stood first in the hypertension challenge. We are also participating in Save Your Feet campaign. Monthly virtual CME, we are now arranging or organizing monthly virtual CME on monthly basis without fail. This month we could not manage to the conference, but again we have informed that we are going to organize it on 27th or 27th of this month without fail. Then zonal member, we have Dr. B.K. Singh sir has been elected as zonal member. Research retreat 2027, we have been allotted the research retreat 2027 at Bodh Gaya. Then there are certain challenges for me also. Membership is again, still it is poor, because most of the small estates, they are having 1200, 1500 or 2000 members. But anyhow, we are struggling between 600 to 700 right now, 667. We have started at 448. And 667 or 668, we are struggling in between that. So, welcome sir, our patron H.K. Singh sir and our patron Ajay sir. On behalf of RSSDI BIHAR, we are welcoming you. So, again, membership is again a challenge, and our target is that we should achieve at least 1200 in next 1 or 2 years. So we are carrying forward these things, and let us hope that we will get that, or we will achieve that. Then research projects, there are so many pending research projects. For that we are working. Our chapter chairman is also working continuously on that, and we will come out with some solution regarding the ethical clearance on we hope that in next year we will have some beautiful or some robust research projects under RSSDI banner. CME, though we are doing virtual CME, but virtual CME has some limitations. Even though we are almost more than 100 participants are participating in those virtual CME, but even then physical CME is not an alternative of the virtual CME. So we will try to organize physical CME also. Aggressive community outreach again is the dream project, so we will try to align and we will do aggressive community outreach in coming months. As far as participants in national conferences are concerned, we will again try for next conference, we will again try to get our berths of chairperson or speakers as many as possible. That is also a challenge for me or for us. Then regarding state conferences, earlier also state conferences are going on, but we are hardly getting any savings in our RSSDI BIHAR account. So finance is a challenge, but from last conference in Aurangabad, there are pretty good amount was donated or rather saved for RSSDI BIHAR account, and we are hoping that this conference also we are going to outnumber or we are going to getting some sort of savings more than Aurangabad conference. We are trying to manage that. So finance is a challenge, but we are trying to swell our finance, swell our balance so that we can plan some other activity. So these are my challenges and achievements. So thank you for your questions. Now coming to the next agenda, conference related matter. So any member regarding the conference related matter, any member if you would like to say, chairman has permitted you. Okay. Dr. Naveen, you would like to say? Yes.
जैसा कि हम लोग पिछली बार अभी जो लास्ट मंथ में
माइक दीजिए
लास्ट मंथ अभी कोचिंग कॉन्फ्रेंस में नेशनल कॉन्फ्रेंस में हम लोग गए थे, तो वहाँ पे रिसर्च रिट्रीट के लिए जो हम लोगों को अलॉटमेंट मिला। बट एक चीज़ मुझे कहना है कि किसी भी संस्था को ऑर्गेनाइजेशन को चलाने के लिए फंड्स की ज़रूरत होती है, तो फंड्स रेज करना किस तरह से रेज किया जाए। तो सबसे बड़ा जो यहाँ पर है ये जो कॉन्फ्रेंस हम लोग करते हैं, तो उसमें ये हमारा प्रपोजल है कि उसमें कुछ ऐसा गाइडलाइन बनाया जाए कि जो भी डिस्ट्रिक्ट में या जो भी लेते हैं स्टेट कॉन्फ्रेंस, तो उसमें एक मिनिमम क्राइटेरिया हो कि कुछ फंड्स जो है वो ऑर्गेनाइजेशन में आए, और जिससे कि आगे हम लोग कुछ उसमें कर सकें। तो इसमें अगर जैसे जो टोटल कलेक्शन है उसका एक कुछ परसेंटेज लाइक 20% या समथिंग जो भी डिसाइड किया जाए, या 30% के आसपास में उसको रखा जाए, और मिनिमम 20 लाख का जो है हर एक साल वहाँ से हम लोग फंड रेज कर सकते हैं। और भी क्या क्या चीज़ हो सकता है जिससे फंड रेज करें और ऑर्गेनाइजेशन को मजबूती मिले, और आगे हम लोग को भी बड़ा कॉन्फ्रेंस करने के लिए एक अच्छे फंड की ज़रूरत पड़ेगी इसमें।
Thank you, Dr. Naveen. Anybody else like Dr. Abhijit?
This is a very important suggestion which will strengthen the finances of the state RSSDI and help us in conducting conferences smoothly without worrying about the finances. So I think we should give a good thought on this.
So Dr. Naveen और Dr. Abhijit के कंसर्न से हम लोग सब लोग कंसर्न हैं, और आपको ये जान के खुशी होगी कि अभी तक हमारा RSSDI बिहार का GST अकाउंट नहीं था। हम लोग हर बार कॉन्फ्रेंस में टेम्पोररी GST अकाउंट लेते थे और फिर उसको 3 महीने या एक्सटेंड करके 6 महीने में क्लोज करते थे। बट अभी हमारे टीम और जो नई टीम थी वो टीम के सतत प्रयास से, चैप्टर चेयरमैन, ट्रेजर और सबके सतत प्रयास से हम लोग परमानेंट GST RSSDI बिहार का मिल गया है, और अब हमें RSSDI बिहार के अकाउंट में सेविंग करने में कोई दिक्कत नहीं है। कोई हम अगर CME कोई भी हम और ये करते हैं अगर, तो हम उसमें RSSDI बिहार के अकाउंट में लेके उससे कर सकते हैं, तभी हमारा अकाउंट और हमारा फिनेंस उसमें स्ट्रांग होगा। तो डॉक्टर नवीन और डॉक्टर अभिजीत के इसमें हमारा ये कहना है कि वैसे आप लोग डिसाइड कर लीजिए, लेकिन मेरा उसमें ये प्रपोजल है कि जितने भी अब स्टेट कॉन्फ्रेंसेज हों उसमें हम लोग ये राइटर लगा दें कि 30% ऑफ टोटल कलेक्शन और 20 लाख विच एवर इज हायर। ये आपको विच एवर इज बिगर वैल्यू, ये आपको RSSDI बिहार के लिए बचाना पड़ेगा। अगर आप 60 लाख कलेक्ट कर रहे हैं तो आपका 18 लाख आप मान के चलिए कि आपको RSSDI बिहार के अकाउंट में आपको देना है, और बाकी भी आप अपने कॉन्फ्रेंस के लिए खर्च कर सकते हैं। तो ये अगर आप लोग का इसमें क्या मत है बताया जाए, सारे मेंबर्स अपना राय दें, इस प्रपोजल में आप लोग का क्या राय है?
Sir, I had this understanding that whatever money is saved remains with the association.
Yes. Of course, sir. But in last 2-3 conferences, we have some bitter experience, sir. Actually, people have collected suppose 60 lakhs, but we could hardly get 3 or 4 lakhs in RSSDI.
Oh, okay.
That is the issue major issue.
But RSSDI के जो अकाउंट ओपनिंग है, RSSDI की जो स्टेट कॉन्फ्रेंस है, उसको भी तो सेम पैन नंबर मिलता है जो नेशनल RSSDI के माध्यम से होता है। तो आप अलग से फंड कहाँ मैनेज कर रहे हैं?
नहीं,
वो अकाउंट तो सबके सामने ओपन है। तो ऑर्गेनाइजिंग कमेटी के पास जो पैसा है वो RSSDI का पैसा है। जो पैसा बचा वो वापस RSSDI स्टेट को जाएगा।
बिल्कुल।
तो इसमें ये राइडर लगाने का जरूरत क्या है?
जरूरत ये है कि एक्सपेंडिचर
तो आपको
मैं समझ गया ये क्या करना, ये कहना चाह रहे हैं कि पहले आप 20 लाख रुपया बचा लीजिए और जो बचे उसी में कॉन्फ्रेंस मैनेज कीजिए।
नहीं सर,
ये नहीं कि 60 लाख कलेक्ट किए तो 55 लाख खर्च कर दिए और बोले कि अब 5 ही लाख बचा। तो 5 ही लाख
ज्यादातर जगह पे ऐसा ही होता है, लेकिन RSSDI में ऐसा नहीं होता था। अगर ऐसा होता था तब तो ये ठीक है, अगर ऐसा हो रहा है तब तो ठीक है। अगर हो रहा है तब तो ठीक है,
तभी ये जरूरत पड़ रही है।
लेकिन ये एक इनहिबिटरी स्टेप होगा स्मॉल स्टेट्स के लिए, स्मॉल डिस्ट्रिक्ट्स के लिए।
इसके पीछे के बैकग्राउंड को मैं बताना चाहूँगा। सभी लोग हैं और सब लोग जानते हैं, कोई अपने ऊपर पर्सनली ना लें कि बैकग्राउंड ये है कि जब भी RSSDI का कॉन्फ्रेंस हुआ है और फाइनेंशियली हम लोग RSSDI कॉन्फ्रेंस में बहुत ही स्ट्रिक्ट रहते हैं, सेंट्रल लेवल पर भी और यहाँ भी। इन स्पाइट ऑफ दैट बहुत सारे मिसमैनेजमेंट हुए हैं और होते रहे, उसको बहुत देर रोका नहीं जा सकता है। बट इस बार भी RSSDI के नेशनल कॉन्फ्रेंस में 30% का राइटर लगा हुआ है। मतलब 30% आपको कॉन्फ्रेंसेस के द्वारा हम लोग को बचा लेना चाहिए। बचेगा नहीं बचेगा ये तो भविष्य की बात है, लेकिन 30% अगर हम लोग बचा लेते हैं तो ये हम लोग के लिए एक एसेट रहेगा। और किसी भी साइंटिफिक प्रोग्राम या फिर कोई रिसर्च प्रोग्राम है, अगर इनिशिएट करने के लिए हमें पैसा चाहिए तो कहाँ से आएगा? तो ये पैसा रिसर्च ओरिएंटेड प्रोग्राम के लिए है। तो ये इसी कारण, उसी बैकग्राउंड के चलते ये राइडर लगाने की बात सोची जा रही है।
राइडर ठीक है सर, मतलब इसमें कोई प्रॉब्लम नहीं है, लेकिन छोटे छोटे डिस्ट्रिक्ट्स में कॉन्फ्रेंस करने में फिर लिमिटेशन हो जाएगा। 20 लाख रुपया बड़ा मतलब
राइडर तब लगाना होगा जब हम इतना अमाउंट क्रिएट कर लेंगे जिससे मेरा कॉन्फ्रेंस अच्छे से
नहीं, और पैसे तो सब कॉन्फ्रेंस के बाद आते हैं। ज्यादातर पैसे कॉन्फ्रेंस के बाद।
अमित ने जो कहा, अमित ने एक अच्छा पॉइंट आउट किया कि इट इज इजियर टू कलेक्ट फंड व्हेन कॉन्फ्रेंस इज बीइंग हेल्ड इन द कैपिटल, but in the small places we need to spread out, and there it is not so easy to raise the funds.
ठीक है, जो बेस्ट प्रपोजल है आप लोग
सर एक मिनट आई वांट टू क्लैरिफाई। आप जो बात कर रहे हैं ये एनुअल कॉन्फ्रेंस की ही बात कर रहे हैं। हमारे समझ से इसमें कंफ्यूजन नहीं होना चाहिए। मोस्ट ऑफ द एनुअल कॉन्फ्रेंस लास्ट 5-7 साल में उसकी टोटल कलेक्शन इज ऑलवेज 50 और 60 प्लस। तो उसमें 20 लाख हम सेव करवा दे।
एकदम सेविंग करने के लिए कॉन्फ्रेंस आप नहीं कर रहे हैं ना सर?
सेविंग्स के लिए ही कर रहे हैं, इसलिए उसका बेसिक पर्पस आपको बता दें। नहीं, बेसिक पर्पस बता दें। जैसे हम लोग अभी
30% इज गुड अमाउंट, परसेंटेज
सेविंग्स की बात इसलिए आई कि हम लोगों ने बिड करने का बिड कर दिया, and we did not expect that we will be granted, but we were granted, sir. Luckily, the RSDI Research Retreat, which is a prestigious national conference. RSDI का साल में 2 एनुअल कॉन्फ्रेंस होती है, एक एनुअल कॉन्फ्रेंस, एक रिसर्च रिट्रीट। तो रिसर्च रिट्रीट बिहार में आज तक नहीं हुआ है, पहली बार हम लोग को एलोकेट हुआ। रिसर्च रिट्रीट के साथ एक प्रॉब्लम है कि रिसर्च रिट्रीट में फंड सेंटर से कुछ भी नहीं आता है। जो भी बाहर से डेलीगेट आएंगे उनका स्टे एंड एवरीथिंग हैज टू बी अरेंज बाय द स्टेट बॉडी विदाउट एनी हेल्प फ्रॉम द फंड। एंड उसमें दूसरा फैक्टर है, चूंकि उसमें नंबर ऑफ डेलीगेट्स कम होते हैं, इसलिए फार्मा का भी इंटरेस्ट कम रहता है। फार्मा फंडिंग इज मच लेसर देन एनी एनुअल कॉन्फ्रेंस, स्टेट एनुअल कॉन्फ्रेंस। तो रिसर्च रिट्रीट में आपको अपने घर से खर्च करना होता है टू ऑर्गेनाइज दैट, एंड दैट हैज बीन द एक्सपीरियंस इन द पास्ट रिसर्च रिट्रीट्स वी हैव सीन। तो इसीलिए हम लोग ये दिमाग में तभी हम लोग का कोची में बैठ के ही आया कि हम लोग को तब अगर रिसर्च रिट्रीट करना होगा तो वी हैव टू हैव सम फंड इन आवर पॉकेट, तभी हम उसको सक्सेसफुली कर सकते हैं, नहीं तो हम लोग बैंकरप्ट हो जाएंगे। तो तब हम लोग सोचे कि ये हम लोग सेव, अच्छा औरंगाबाद में सर ने सेव करके दिखाया कि उतना सेव हो सकता है, तो दैट हैज एम्बोल्डन अस, दैट हैज गिवन अस होप कि जब औरंगाबाद में सेव हो सकता है तो व्हाई नॉट इन द बिगर टर्म्स।
औरंगाबाद में अच्छा अमाउंट सेविंग हुआ था।
लेकिन दो बात है ना कि सेव करना प्राइमरी इंटेंशन है कि कॉन्फ्रेंस करना
दोनों हो जाएगा।
दोनों इसके पहले तो
हम लोग
इससे पहले अकाउंट नंबर नहीं था।
In 2004,
सर
hello, 2004, I conducted national conference, जिसमें हमको सेविंग हुआ था 18 लाख समथिंग
At that time.
तो हम एट दैट टाइम वो हम यहाँ चूँकि ब्रांच नहीं अप्रूव था, टोटल मनी दे दिया बेंगलोर में। नेक्स्ट कॉन्फ्रेंस था सेंट्रल बॉडी, लेकिन उस समय रूल था कि अगर जो अप्रूव्ड ब्रांच 40% ब्रांच में पैसा रह जाएगा और 60% सेंट्रल। ये एग्जिस्टिंग रूल था
उस समय, रूल था
उस समय।
अच्छा, इसमें एक और राइडर है विजय कि तो आप जो स्टेट जो है जिस बॉडी को कॉन्फ्रेंस करना है, सपोज दरभंगा को करना है, तो स्टेट उस डिस्ट्रिक्ट को कितना पैसा देगी?
कुछ भी नहीं।
क्यों नहीं
के पास रहेगा
उसको कंट्रीब्यूट करने के लिए कुछ पैसा
स्टेट के पास फंड रहेगा तो
उसमें ये है कि शुरू में सेंटर 5 लाख देती है
वो भी
स्टार्ट करने के लिए, बिकॉज शुरू में उनको बहुत सारा ये देना होता है,
लोन मिलता है,
लोन मिलता है।
हाँ, लोन मिलता है, वो सीट मनी दीजिएगा ना।
हाँ, वो तो मिलता है, वो मिलता है।
वो राइडर वो भी
अगर आप लोग को 20 लाख ज्यादा लग रहा है तो परसेंटेज कुछ कर दीजिए, बिकॉज उसमें है क्या कि सर कॉस्ट कटिंग आप अननेसेसरी का कल्चरल प्रोग्राम बहुत एक्स्ट्रा वगैरह करके अगर उसमें आप कर रहे हैं तो वहाँ आप कट शॉर्ट करिए, वहाँ कॉस्ट कटिंग करिए। कॉन्फ्रेंस के क्वालिटी में, फूड के क्वालिटी में, हॉस्पिटलिटी में, गेस्ट के हॉस्पिटलिटी में उस पर नहीं करिए। हम लोग अभी इस कॉन्फ्रेंस में सर एक्स्ट्रा वगैरह जैसे कल्चरल वगैरह हम लोग ज़्यादा नहीं कर रहे हैं। हो सकता है आप लोग इसके लिए नाराज होंगे थोड़ा कि कल्चरल बहुत अच्छा नहीं हुआ, लेकिन कॉस्ट कटिंग हम लोग वहीं कर पाएंगे सर, अदरवाइज हम लोग कॉस्ट कटिंग नहीं कर रहे हैं। ऑर्गेनाइजिंग कमेटी की मीटिंग हम लोगों ने जितनी की उसमें हम लोगों ने 1 पैसा खर्च नहीं किया। किसी फार्मा से स्पॉन्सर करा के हम लोगों ने ऑर्गेनाइजिंग कमेटी मीटिंग की। प्रेस मीट के लिए हम लोगों ने किसी फार्मा को इन्वॉल्व किया, लेकिन अपने कलेक्शन से हम लोगों ने कहीं वो खर्च नहीं किया। तो वो कॉस्ट कटिंग एग्जाम्पल बन सकता है, वो आप लोग भी कर सकते हैं। हाँ, सेविंग जहाँ तक सवाल है कि 20 लाख नहीं हो सकता है तो कुछ परसेंटेज का राइडर कर दिया जाए, लेकिन अगर ये नहीं करेंगे तो कलेक्शन होता है लेकिन RSSDI बिहार के इसमें नहीं आता, तो फिर कैसे रिसर्च रिट्रीट कैसे होगा, या आगे आपको नेशनल कॉन्फ्रेंस करना है तो कैसे होगा? दैट इज एन इम्पोर्टेंट।
हमारे ख्याल से कि 30% का राइडर लगा दीजिए,
20 लाख हटा दीजिए, 30% का राइडर, अगर सब लोग एग्री हो तो 30% का राइडर लगा दीजिए।
जो लोग नहीं देंगे उनको क्या पनिशमेंट दीजिए?
वो पहले ही हम लोग उसमें उतना उनको खर्च करने ही नहीं देंगे, उसमें ऐसा ही करेंगे प्रोविजन।
नहीं खर्च करने दीजिएगा तो आपके गेस्ट नहीं तो इंसल्ट हो जाएगा।
नहीं सर, वो 30% 70% कलेक्शन
नहीं, इतना राइडर तो लगाना होगा कि 30% तब लेना है जब कलेक्शन इतना रफली हो।
तो ठीक है सर, वो भी बताइए सर। उसमें अजय सर का सजेशन है कि 30% का राइडर तब लगाइए जब मिनिमम इतना कलेक्शन से एबव हो जाएगा, तब 30% देना पड़ेगा। वो भी अगर ठीक है कि उससे कॉन्फ्रेंस का कॉस्ट आ जाए तो ऑफ कोर्स सर कि उसके बाद ही ये 30% का राइडर रहेगा। कोई कलेक्शन कहीं कम होगा तो ऐसा नहीं है कि हम लोग बोलेंगे कि नहीं दे ही दीजिए आप, ऐसा नहीं होगा सर।
उस केस में तो आपको देना होगा फिर उसको हेल्प
तो ऐसा नहीं होगा। हैंड होल्डिंग के लिए हमेशा RSSDI बिहार तैयार है, लेकिन कॉस्ट कटिंग कम से कम हो पाएगा या एक्स्ट्रा वैगेंजा थोड़ा सा वो
एक्स्ट्रा वैगेंट नहीं होना चाहिए।
हाँ, तो वो चीज ये कर सकते हैं हम लोग।
30% ठीक है उसको।
ठीक है।
तो सब लोग सहमत है कि 30% का राइडर लगाया जाए, एजीएम पास करती है
30% of total amount deposited.
Collection. Yes.
Not saved.
No. Collection. 30% of total collection should be transferred to the RSSDI BIHAR account.
Okay.
So AGM ने इसको ध्वनिमत से पास किया. Thank you. Now coming to the next agenda, that is 9th annual conference bidding. We have 3 proposals. One is from Purnia, led by Dr. R.K. Modi sir. Another is from Sasaram, led by Dr. Abhishek Kamendu and Mahendra Pratap. And one is again from Patna. So now we have to decide कि 2027 का, ये तो 26 का कॉन्फ्रेंस हो रहा है, 2027 का कॉन्फ्रेंस कहाँ होना है, बिकॉज उसी साल हम लोग को रिसर्च रिट्रीट भी करना है.
तो पटना तो आउट ऑफ क्वेश्चन है बिकॉज अभी हुआ है.
यस सर.
तो बिटवीन सासाराम एंड पूर्णिया लेट्स ऑफ.
यस सर. तो पूर्णिया के लिए कितने लोग रेडी हैं? पूर्णिया के लिए, सासाराम के लिए कितने लोग रेडी हैं? सर तो उसमें ऐसा किया जाए कि टेक्नोलॉजी में बिडिंग मोदी सर का काफी पहले आ गया हुआ था और इन लोग का बिडिंग अभी 1 हफ्ता पहले आया.
अभी हुआ भी था.
अभी तो औरंगाबाद हुआ भी था.
पूर्णिया एक बार कर दीजिए,
उसके बाद हम लोग आगे उसको कंसीडर कर सकते हैं, बिकॉज अभी सासाराम हुआ भी था और टेक्नोलॉजी में मोदी सर ने काफी पहले ये किया था कि पूर्णिया करना है. तो
और मोदी सर 30% दे भी लेंगे.
और मोदी सर से हम लोग
मोदी सर बोले थे वहाँ पर कोचिंग
नहीं हम तो 35% बोले थे.
मेरा हम जानते हैं मोदी है तो मोदी है.
25 लाख बोले थे.
30% हमारे 35% बोले थे.
बचाने का क्या है?
40%
नहीं. अब ये चीज बीच में भी कोई अगर जैसे दरभंगा में या मुजफ्फर, हाँ बोलिए, मैंने कुछ कहना है.
ये तो फेयर नहीं है ना. पिछले कॉन्फ्रेंस में ही हमने बिडिंग किया था.
नहीं मैं डॉक्टर महेंद्र,
और तब हमारे सुप्रीम मुखर्जी सर ने कहा था कि गिवन द नेक्स्ट कॉन्फ्रेंस टू सासाराम.
नहीं मैं बता रहा. अच्छा एक मिनट डॉक्टर महेंद्र, जो बिडिंग किया मैं बता रहा.
दिस ऑल थिंग वाज ऑलरेडी
मैं बता रहा हूँ. जो औरंगाबाद को, सही बात है कि औरंगाबाद कॉन्फ्रेंस के तुरंत बाद उन्होंने बिडिंग की थी सासाराम की. उसमें वो बिड हो गया हुआ कि नहीं पटना होगा, तो वो प्रपोजल ड्रॉप हो गया. अब जब फिर नल एंड वॉइड हो गया, अब जब फिर नया प्रपोजल आपको देना था, तो आपने अभी दिया ना 1 हफ्ता पहले. ऐसा तो नहीं कि आप पिछले प्रपोजल पे स्टैंड किए, आपने दिया.
ऑलरेडी प्रपोजल दे दिया.
नहीं आपने फिर एक ऑफिशियल प्रपोजल दिया ना, वो आपको देना था. ऑफिशियल प्रपोजल तो फिर वो तो नल एंड वॉइड हो गया ना, तो फिर देना था, जिसमें मोदी सर ने दिया था और पूरा हाउस डिसाइड करे कहाँ करना है, उसमें तो हम लोग कोई आपत्ति नहीं. ये तो है. बोलिए भाई, पूर्णिया के लिए कितने लोग? पूर्णिया के लिए इतने लोग तैयार हैं, तो बाकी बचे लोग माइनॉरिटी में हैं जो सासाराम के लिए तैयार हैं.
नहीं माइनॉरिटी में नहीं है. तो रिक्वेस्ट कीजिए कि इनको अगली बार करें.
हाँ अगली बार.
एक प्रपोजल ये है, अभी अगर मान लो कि दो कॉन्फ्रेंस का हम लोग डिसाइड कर सकते हैं इस एजीएम में.
हाँ कर सकते हैं.
तो अगर मान लीजिए कि हाउस ज़्यादा लोग अगर एग्रीड है या अगर आप चाहते हैं कि वोटिंग हो जाए, एग्रीमेंट हो जाए, तो आपको लगता है वोटिंग अगला बार सासाराम कर दो. उसके नेक्स्ट ईयर
अगर ये लोग तैयार हो,
ठीक है.
क्या विषय एग्रीड हो तो नेक्स्ट उसके बाद वाला कॉन्फ्रेंस हम लोग इसी एजीएम में तय करते हैं. फर्स्ट ये 27
उसके बाद
वाला शासन
एश्योर कर दिया जाए.
एश्योर हो जाएंगे.
और हम लोग सासाराम टीम की तरफ से भी ये भी एश्योर्ड है कि वो लोग मोदी सर के 30% को 30% तक ले.
बिल्कुल.
दो कॉन्फ्रेंस
तो हम लोग का ये हो गया, एजीएम में पास किया कि 2027 का पूर्णिया में और 28 का सासाराम में होगा. और पूर्णिया में 30% और ये लोग उसका भी रिकॉर्ड छोड़ेंगे, उनको भी लागत देते हैं. ठीक है, बहुत बढ़िया. देन अगला सर ये है कि एनी अदर मैटर. उसमें एक मैटर हमारा है सर कि हम लोग बीच बीच में भी मिड टर्म अगर नहीं करते हैं, बिकॉज अब हमारे पास परमानेंट जीएसटी है, तो फंड जनरेशन के लिए हम लोग बीच बीच में भी छोटा मीटर टाइप का या वनडे का कॉन्फ्रेंस रिमोट एरिया में कर सकते हैं। उसमें सारा अकाउंटिंग हैंडल हमारा सेंटर से हो जाएगा, बिकॉज वहाँ उसको अकाउंटिंग हैंडल करने का फिर अकाउंट खोलिए या कैसे ये करेंगे, तो सेंटर से हैंडल हो जाएगा। वहाँ के जो ऑर्गेनाइजिंग सेक्रेटरी रहेंगे वो सेंटर में लेंगे और सेंटर से पैसा खर्च कर लेंगे, और इस तरह करके उसमें एक बीच बीच में भी सेविंग का जरिया बन सकता है। बिकॉज 2027 का जो रिसर्च रिट्रीट है वो हमारे लिए एक मेजर चैलेंज है, जिसमें अच्छा बजट खर्च होना है, और चूंकि उसी समय एनुअल कॉन्फ्रेंस होगा फरवरी में या जनवरी में, और तुरंत रिसर्च रिट्रीट 2 महीने में होगा, तो फंडिंग के लिए वो प्रॉब्लम होगी। तो दोनों फंडिंग अमलगमेट करके चलना पड़ेगा कि उस हिसाब से बीच में हम लोग ऐसा कर सकते हैं। अगर आप लोग कहें तो बीच में हम लोग इस तरह की एक्टिविटी करें जिसमें RSSDI बिहार के फंडिंग से हम लोग RSSDI बिहार में लें और वहीं से खर्च करें।
इसमें क्या
तो उसमें 1-2 प्रपोजल है सर जो हम बताना चाहेंगे। उसमें एक प्रपोजल है हमारे डॉक्टर SC झा सर का, इनकी काफ़ी पहले से बात हो रही थी अनुज महर्षि सर से। अनुज महर्षि आने के लिए एग्रीड हैं। 6 या 7 फरवरी को सीतामढ़ी में एक कम्युनिटी आउटरीच और साथ में होली ट्रिप है जनकपुर का, और वहाँ कम्युनिटी आउटरीच और एक CME करने का सबका प्लान है। तो हम लोग क्यों नहीं एग्जाम्पल सेट फरवरी से ही करें कि हम लोग RSSDI बिहार के अकाउंट में लेके वहाँ से खर्च करके GST का भी कोई प्रॉब्लम नहीं होगा, कोई अकाउंटिंग का भी प्रॉब्लम नहीं होगा, और थर्ड पार्टी भी आजकल पेमेंट दिक्कत होती है, तो सारा RSSDI बिहार से ऐसे करके हम लोग कर सकते हैं। तो उसमें सीधा सर आपका क्या कहना है सर, आप बताएं सर। माइक दीजिए सर।
सर बिना माइक के भी बोल नहीं, इसमें ऐसा है कि दिस हैज नॉट बीन प्रॉपर मैंने फाइनलाइज्ड एज येट। वो 1-2 दिन में वो फाइनलाइज करेगा। जिस समय हम लोगों ने DMCH में किया था मेडिसिन अपडेट और वहाँ पर विलेज आउटरीच प्रोग्राम, उसी समय में बातचीत में ही एक्सप्रेस द डिजायर टू विजिट सीतामढ़ी, बर्थ प्लेस ऑफ गॉडेस सीता, एंड ही आल्सो वांटेड टू पे अ होली विजिट टू दिस। एंड और मैं था और विजय और नवीन, तो उन्होंने कहा कि आप लोग जैसे एक प्लान कीजिए। तो वही प्लानिंग के जो है 6-7 को जो है हम लोग कर रहे हैं। तो उसमें एक जो है छोटा CME हम लोग प्लान कर सकते हैं। और जैसे कि अभी बात हो रही थी एलोकेशन वगैरह की, हम लोग का एक एम ये भी होना चाहिए कि ये जो कॉन्फ्रेंस का जो जिस्ट है वो हम लोग के पेरिफेरल पॉइंट्स पर पहुंचना चाहिए। वहाँ पर और भी यदि हम लोग को सेंटर से भी यदि मदद हो, चाहे जो हो जैसे हो, वहाँ पर फार्मा मैंने मैचिंग फंड उतना नहीं होता है जितना कि सेंटर लेवल पर। तो दिस विल बी मे बी अ गुड स्टेप कि यदि अनुज वहाँ पर आते हैं और वहाँ पर यदि हम लोग कुछ करते हैं, और ठीक है वो तो होली विजिट तो उसका पर्सनल अपना है, तो उसी को एक छोटा सा प्रोग्राम
दोनों जगह नहीं कीजिए प्रोग्राम एक ही जगह,
प्रोग्राम एक ही जगह होगा।
प्रोग्राम सीतामढ़ी में
होगा, और वहीं पर एक जो है विलेज में वो जो है सो कैंप वैम्प और कुछ वो जो बाग टाइप का, जिस तरह से हम लोग दरभंगा में किए उस तरह से कर सकते हैं। और बिहार जिस मामले में कर सकता है, आई स्टिल रिमेंबर द डे हैदराबाद में कॉन्फ्रेंस था, अजय सर फर्स्ट चैप्टर खोलने वाले थे। उस समय जो है सो सर बोले कि सुधीर ऐसा ऐसा तुम तो मेडिकल कॉलेज में हमको हेल्प चाहिए। बोला कि सर आप लोग तो सब पटना वाले कर लेते हैं, बाहर वाले को पूछते कहाँ है, लेकिन तुम पार्टिसिपेट करोगे? तो लगे हम क्यों नहीं करेंगे सर। एंड आई वॉज द फर्स्ट स्पीकर इन द फर्स्ट कॉन्फ्रेंस, थैंक्स टू द ब्लेसिंग्स ऑफ डॉक्टर अजय कुमार सर। तो अजय कुमार सर इज रिस्पॉन्सिबल फॉर टेकिंग दिस to the periphery, to the districts, and let us proceed ahead and still further and keep it to the most peripheral point where our colleagues are working under adverse circumstances.
So in adverse situation you have done conference, so you are Hanuman.
उसमें एक भी बहुत important concern है which I can foresee, that the pharmaceutical companies will be very reluctant to spend money when a conference is held in a remote area. So people in the big cities like Patna and others will have to ensure to put pressure on the pharma houses to provide money for such conferences.
Yes sir, yes sir.
क्योंकि वहाँ का लोकल ऑर्गेनाइजर परेशान होकर रह जाएगा।
Yes sir.
कहेगा कि इसके लिए हम क्यों दे पैसा? नहीं, बहुत मुश्किल है। Emotionally it is right, but logistically it will be a nightmare.
लेकिन इसका दूसरा पहलू ये भी है सर कि अभी तक जो दिक्कत होती थी, जैसे कोई फार्मा अगर ये करता है तो वो कहता है कि हम थर्ड पार्टी ये नहीं कर सकते हैं सर, हम आपको देंगे, आप खर्च करिए टिकट का या इसका। तो GST अब हो जाने से हम लोग
वही हम कह रहे हैं, that advantage has to be turned into reality by putting a lot of pressure from every quarter. ये कहा ठीक है भाई, अब सुधीर जी का प्रॉब्लम है तो सुधीर जी अपना मैनेज करें, इस एटीट्यूड से होगा तो नहीं होगा।
नहीं, वो जॉइंट एफर्ट करना पड़ेगा उसको,
Joint effort, everybody has to be involved, and if you can do that, that will be the example before rest of the country.
Yes, sir. Now next proposal is
you will convey how much budget you have, and you will convey to the state RSSDI.
Of course.
And then they will decide.
वो तो है ही, वो transparency will be there.
ठीक है।
अभी कंसेप्चुअली एग्री करते हैं।
दूसरी बात है सर कि दरभंगा वाले कॉन्फ्रेंस में भी हुआ, कभी-कभी वहाँ के मेंबर्स जो ऑर्गेनाइज करते हैं उनको लगता है कि RSSDI बिहार इंटरफेयर कर रही है, लेकिन चूंकि RSS सबको ये समझना पड़ेगा कि RSSDI बिहार का कॉन्स्टिट्यूशन ही ऐसा है कि RSSDI बिहार को ही प्रोग्राम करना है, आप सिर्फ RSSDI बिहार के रिप्रेजेंटेटिव बनते हैं वहाँ एज ऑर्गेनाइजिंग सेक्रेटरी और एज ऑर्गेनाइजिंग चेयरमैन। तो ऑफिस बियर को कॉन्फिडेंस में वहाँ ऑटोनॉमी या ऑटोक्रेटिक नहीं हो सकते हैं, आपको RSSDI बिहार के ऑफिस बियरर्स को लेके ही चलना पड़ेगा। उसमें कभी आपको ये ऑफेंडेड फील नहीं करना चाहिए कि हम दरभंगा में कॉन्फ्रेंस कर रहे हैं और पटना से आप फरमान जारी कर रहे हैं।
ओएस के लिए आपको एक
डोमिनेट करने का सवाल ही नहीं है, डोमिनेट करने का सवाल ही नहीं है, लेकिन यहाँ पर ये है कि people sitting at the stronger place must be empathetic to the places.
Absolutely.
Where,
of course, sir. Of course, sir.
There has to be at least one interaction.
No, you cannot dictate the things as you do in Patna.
Of
But
course,
there has to be one interaction between the chairman and the organizing secretary.
but narrative and advisory from RSSDI Bihar should be applicable at this.
It will be. It will be.
नहीं, rules has to be followed, नहीं sir.
एक इंटरव्यू चाहिए हो खत्म कीजिए नेक्स्ट काम जो है
जल्दी करो
पर लोग परेशान हो रहे हैं
और को आप किसी को कुछ कहना नहीं है, कहना है
आपको एक चीज कहना है, नहीं सबसे पहले मैं दो तीन सजेशन देना चाहूँगा। पहला बात है कि फाइनेंस एक ऐसा चीज जिसमें 1 रुपया भी इधर से उधर होता है तो लगता है कि बहुत बड़ी गड़बड़ी हो गई। सो मेरा हम्बल रिक्वेस्ट है मनीष जी से कि आप 31 जनवरी का एक इनकम एक एक्सपेंडिचर बेसिक बना करके एजीएम में सर्कुलेट कर दीजिए कि दिस इज द फाइनेंशियल सिचुएशन ऑफ दिस 31 मार्च। आपने बताया उसको सर्कुलेट कर दीजिए, ओके सर्कुलेट कर दीजिए, आपने बताया बिल्कुल राइटली। सेकेंड पॉइंट ये है कि ठीक है, ये जो हम लोगों ने बहुत हमने जो एजीएम को हम लोग नेगलेक्ट करते रहे थे, तो उस एजीएम को फिर से हम लोगों ने रिवाइव किया है, तो उसके लिए थैंक्स टू द Supriyo and Manish and Sawal and Vijay. So big round of applause to them. थर्ड बात मेरा एक पर्सनल ये है कि मैं RSSDI के मेंबर हूँ, उसी तरह हमारा ट्रस्ट है जो 3.5 मेंबर ट्रस्ट भी है, जिसने कि प्रेमिसेस औरंगाबाद में दिया था विद द कंडीशन, क्योंकि मैं दोनों जगह रिप्रेजेंट करना है, इसलिए मुझे ही ये कंडीशन दिया गया था कि हम आपको प्रेमिसेस फ्री ऑफ कॉस्ट दे रहे हैं, लेकिन आप एक कोई छोटी सी भी फेवर हमारे फेवर में कीजिएगा कि ये कोई भी एक प्रोग्राम या कोई भी एक अवार्ड हमारे नाम पर एक देने की कोशिश कीजिएगा। तो मेरा ये हम्बल रिक्वेस्ट है, हम रिक्वेस्ट लेटर फिर से भेजेंगे आपको अपने ट्रस्ट की तरफ से, लेकिन ये रिक्वेस्ट है कि उसके बारे में उसको सिंपैथेटिकली सोचते हुए तो यही कहना था। थैंक यू वेरी मच।
थैंक यू सर। हाँ कुछ बोलना है आपने, बोलिए
सर। एक और मतलब थोड़ा सा और जो फंड रेजिंग की जो बात हुई थी कॉन्फ्रेंसेस की या जो भी होता है, तो जो कल्चरल इसकी बात हुई थी, मे बी आई एम वेरी नॉट वेरी मच एक्सपीरियंस टू से दिस, ऐसा भी हो सकता है कि कल्चरल इवेंट खुद अट्रैक्ट करे न्यू पेड रजिस्ट्रेशंस को, जिससे कि फर्दर फंड रेज किया जा सके।
लेकिन हम लोग का मोटो डाइवर्ट हो जाएगा, वो हम लोग कल्चरल से फंड रेजिंग का कोई
आई डोंट नो दैट
फंड रेजिंग में हम लोग का साइंटिफिक रहे, हम लोग नहीं डॉक्टर ना हम लोग साइंटिफिक रहे, कल्चरल से हम लोग फंड रेजिंग का उतने कुछ नहीं जाए।
You do not
ठीक है सर। नाउ मे आई इनवाइट आवर चैप्टर चेयरमैन फॉर हिज स्पीच।
Very good evening, sir, patrons, sir, esteemed members. हम लोग के पास समय कम है, विजय सारी बातें डिस्कस कर लिए हैं और हम लोग अभी इनॉग्रेशन प्रोग्राम में हम लोग डिस्कस सारी बातें फिर करेंगे, क्योंकि हम लोग के पास समय कम है, तो अभी हम लोग कट शॉट करते हैं, फिर हम लोग वहाँ बात करते हैं। थैंक यू सर।
Now there is a ceremony, sir. Now there is those ceremony will be there in inauguration, but collar change is usually custom in AGM. So may I invite our chairman elect?
सर यहाँ पर एक सेरेमनियल 1 मिनट का कर लीजिए, जो नियम है वो कर लेते हैं। आ जाइए शबाब,
फिर आप ले लीजिएगा क्या?
और फिर वहाँ पर आप असर जाएगा। अभी ले लेंगे तो
रिहर्सल
से खड़ा हो जाएगी।
So big round of applause for our outgoing chairman and incoming chairman.
Very strong and responsible.
Now may I invite our chairman elect and incoming chairman Dr. Sehwal sir for few words.
अभी हमको पहला
Respected seniors, dear friends, it is a proud privilege that you have got me capable for this position, and I thank everybody for this. And I strive to maintain the set standards, the high standards which have been set by my predecessor, Dr. Mukherjee. And I am fortunate to have a wonderful team with me, with Dr. Subhash, Dr. Vijay, Dr. Manish, and everybody. So I think I am almost sure that we will be able to continue the same academic endeavors with the same speed, and in fact we will strive more in our other activities, the education, the PGA awareness, the community outreach programs. And we will try to continue and upgrade all of the activities which we are doing. Thank you. Thank you.
Thank you very much for all of you for coming, for your sparing valuable time. So now I am inviting you for inaugural function at the main hall. Thank you.
बहुत बढ़िया।